to take the citation of the different guest speakers. It is their show. And so we're putting them on the right track, not only in the clinicals, but also how to encore programs in the college. I want to say good afternoon to Madam Provost, Professor Mrs. Benis Adegbengbe, for coming on time. You're welcome. Thank you, ma'am. Also in the house, we have the Deputy Provost, Professor Okola. Okola, thank you very much, sir, for being around. Also, our big professor, Professor Razak Adebayo. Welcome, sir. In the house, we also have Professor Darie Song from Orthopedics, Professor Akinsulure from Mental Health, Professor Adekwiti ONG, Dr. Oladoko from Nursing Science. So this is our show. So I will hand over to the MC, Miss Apampa. Over to you.
All right. Good afternoon, highly respected ladies and gentlemen in the hall. How are we doing today? Good afternoon to all the dignitaries in the house, to all our professors, and I want to say a big thank you to you, Ma, Professor Zenge, for giving me this opportunity. Thank you so much, Ma. All right, so right about now, as you introduced, my name is Muturayo Apapa, and I am honored to be your anchor / master of today's ceremony. So can you find someone, make eye contact. Oh, thank you very much for the applause. So make eye contact with someone on your left and someone on your right. And say this to them: welcome to 2026 Preceptorship Programme. If they are not listening to you, or if they are not saying it back, look for someone else, smile, and tell them this: welcome to 2026 Preceptorship Programme. You are about to have a great time. You will not regret you are here. All right, very quickly, please can we rise to our feet as we take the national anthem? Thank you.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace all battle honored, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant this our one request. Help us to build our nation where no man is oppressed, and so with peace and plenty Nigeria may be blessed.
I love you.
All right, we're going to be moving on to the next thing on the program for today, and we're going to be diving straight into the welcome address. All right, before we move straight to the welcome address, we are going to be introducing, we have some very important people in our midst today, distinguished personalities in our midst, and it is definitely a great honor for us to have them in our midst. So, first on the list, I would be recognizing the presence of our dearest provost of the College of Health Sciences, the ever sophisticated and elite Professor Mrs. B.O. Adegbeyide. Welcome, and please let's keep clapping till she gets to the high table. Thank you so much, ma, for joining us. All right. We also have in our midst a very distinguished personality and person of our very own Deputy Provost of College of Health Sciences, in person of Professor Okunola. Thank you so much, sir, for joining us here today. Really appreciate you. All right. All right. Like it was introduced earlier, this is the Preceptorship Programme hosted by the College of Health Sciences and the College Alumni Relations Body. So in our midst, we have the President of the Alumni Body of the College Alumni Body, in person of Professor Adebayo. Thank you so much for joining us. Please, you can come to the high table, sir. Thank you, sir. All right, now that we're all fully settled, we'll dive right into the next thing in the order of the program, and that is when I call this person, this personality, this distinguished person, I want us to keep clapping when I hand over the mic to her. So we are going to be having the welcome address by our very own, ever sophisticated and elite Provost of the College of Health Sciences, in person of, some of us are not clapping yet, in person of Professor Mrs. Bernice Adegbeyide. Thank you so much, ma'am.
Thank you, Mr. Pampa. God bless you. Well done. Yes, another preceptorship program. So I want to welcome every one of you. And I'm glad that most of our students are here, because this program is mainly for the students and for our faculty in the college. Distinguished guests, respected members of the College of Health Sciences and the university community that are here, my esteemed colleagues, healthcare professionals, our preceptors, students, ladies and gentlemen. It is with great pleasure and deep gratitude to God that I warmly welcome you all to this year's Preceptorship Program. I consider it both honor and a privilege to give an opening remark at this great academic gathering. Today's theme, mental health among healthcare professionals, identifying challenges and charting the way forward, is not only timely but profoundly significant in our contemporary healthcare environment. The choice of this theme reflects our collective recognition that the well-being of healthcare workers is inseparable from the standards of quality of care delivered to patients and communities. Healthcare professionals occupy a unique and demanding position in the society. Every day, we are confronted, because I'm an healthcare professional too, with pain, uncertainty, emergencies, trauma, and sometimes loss of life. Healthcare workers work in long hours under intense pressure, often sacrificing personal comforts and family time in service to humanity. While they are trained to care for others, many silently battle with stress, burnout, anxiety, depression, compassion fatigue, and emotional exhaustion. Unfortunately, mental health challenges among healthcare professionals are often too overlooked or stigmatized. Many suffer in silence because of fear of judgment, professional expectations, and lack of adequate supporting systems. Yet, we must acknowledge that a distressed healthcare workforce cannot optimally serve the society. So caring for the caregivers is therefore not optional, it is very essential. While the sub-theme of today's program, the emergency medical care response, further draws our attention to one of the most demanding areas of healthcare delivery, emergency care. So emergency care providers frequently operate under extreme conditions where rapid decision-making, limited resources, high patient volume, and life-threatening situation define daily practice, especially in this part of the world. Such environments can place enormous psychological burden on the healthcare personnel. This preceptorship program presents a valuable opportunity for knowledge sharing, mentorship, collaboration, and professional reflections. I'm confident that the lecturers of today, they are seasoned individuals. I can tell you that the choice of today's lecturers is divine in the sense that they are the best in the various topics we are going to consider today. Some of them are my classmates, Professor Shazike, who is the president of North American Association of Psychiatry, is one of my classmates. And Professor Chinwe Ogedegbe, we both graduated together from this same university the same year. So you can imagine, and having graduated over almost 40 years ago, you know you are going to have experience talking to you this afternoon. They are full of experience. Dr. Oyedokun and Dr. Umar, they are alumni of this university. So you can see that this university, especially our college, is blessed with individuals that have been well positioned and highly skilled and well placed. So I'm confident that the lectures, the discussion and interaction that will take place here will deepen our understanding and inspire practical solutions that can positively transform healthcare practice and professional well-being. I would like to express my special appreciation to the organizers, the facilitators and resource persons, and all the participants who dedicated their time and commitments and made this program possible. Your efforts demonstrate our shared resolve to build an healthier, more compassionate, and more effective health care system. To our students and young professionals present here today, I encourage you to embrace not only academic excellence and clinical competence, but also empathy, self-care, and emotional intelligence, and mutual support. The future of healthcare depends not only on technical skills, but as we deliberate during this program, I encourage also to critically examine the realities confronting healthcare workers in Nigeria and across the globe, but also on the mental and emotional strength of those who provide care. As we officially commence this program, I sincerely hope that our deliberations will generate actionable recommendations that will improve the welfare of healthcare professionals and strengthen emergency care delivery within our institutions and communities. Once again, I warmly welcome all and wish everyone a productive, enlightening, and impactful program. Thank you. God bless you.
Thank you very much, Ma. That was very... Once again, thank you very much, Ma. All right, so during the welcome address, we had some dignitaries join us, and I was recognizing the presence of the Faculty of Nursing Sciences in person of Professor Shola Go-for-Okon. Please let our applause be as resounding as possible. Thank you so much, Ma, for joining us. It's such an honor to have you in our midst. All right. Also, we have another distinguished personality in our midst, in person of Professor Shola from the Radiology Department. Thank you so much, Ma, for joining us. It's such an honor to have you here. Also, we have members of staff of the Faculty of Nursing Sciences in our midst. Please, can the applause be as resounding as possible? Thank you so much for dedicating your time to join us here today. All right. So very quickly now, we're going to be moving on to the next program. And we're going to be moving on to the first session of the program today, which is as the theme, mental health among healthcare professionals, identifying challenges and charting the way forward. And today, we have this session as the topic goes, mental health among healthcare professionals, identifying challenges and charting the way forward. From the provost address, you can see that we are off to a great start. Do you agree with me? Do you agree with me? So this next session, it is very important that every person here pays attention. Some of us, like myself, including myself, are students, but one day become healthcare practitioners, like our professors here. So we might as well just hear from them. This program is for us. Tell your neighbor, this program is for me. So pay attention. During this session, don't press your phone. Our voices are low with that last statement. All right, so very quickly now we'll be moving on to the first session, and we have two very distinguished moderators for this session. They are seasoned speakers, and the moment I call their names, I want you to drop everything you are doing. Keep your hands as free as possible to jam your hands together to welcome these two people that will be moderating this session. And number one on the list is the none other, the very articulate, my professor, your professor, Professor Akisulore of Mental Health. Thank you so much, sir. Thank you so much, sir. Please come forward, sir. Please, let's keep clapping till I hand over the mic. Thank you. We can do better. Thank you so much, sir. We are so honored to hear from you. Thank you, sir. Also, joining him in this session, joining him to moderate this session, mental health among healthcare professionals, identifying challenges and charting the way forward, is the gorgeous Dr. Oladoko of Nursing Sciences. We can do better with our applause. Thank you so much, Ma. Thank you so much, sir. It's such an honor to hear. Please, let's keep clapping till she gets to stage. It's such an honor to listen to both of you, sir and Ma. Thank you so much. All right, so I'll be handing over the microphones to them now. And please ensure you pay attention as much as you can. Thank you.
Standing on the existing protocol, Madam Dean, good afternoon, Ma. I would like to welcome my Dean, Professor Salako. You are welcome, sir. Can we please jam our hands together for the Dean? So this afternoon, we have two lectures, and what we have done is that, looking at the topic, we've actually divided the topic. Okay. So we have two lectures that will be speaking to the topic we have, and the two speakers, we have Professor Charles DK that will be speaking first, and later okay. So now what we have is that Dr. Ubo will be coming on first, and later Professor DK will be speaking next. So I would like to invite the person that will be taking the citation of Dr. Umo. Ineoluwa, are you around? Okay, can we please welcome her? So.
Good afternoon, everyone. It's my great pleasure to introduce our guest speaker for today, Dr. Ekwere George Umo. Dr. Ekwere George Umo is a consultant psychiatrist currently practicing in the United Kingdom. He is widely recognized for his contributions within the National Health Service, NHS, particularly through his work with the Kent and Medway NHS and Social Care Partnership Trust, also known as KMPT. He currently serves as a consultant psychiatrist at St. Martin's Hospital, where he specializes in general adult psychiatry. In this capacity, he oversees inpatient services, including the Samfre and Fen wards, and plays a significant role in the delivery of. In addition to his clinical responsibilities, Umo is actively involved in postgraduate psychiatric education and professional development. He served as a clinical supervisor and trainer for the Kent Success and Higher Psychiatric Training Scheme, where he mentors core trainees in general adult psychiatry. His educational role reflects his commitment to developing the next generation of psychiatric practitioners and maintaining high standards of clinical training. As part of the Acute or Community Recovery Service line within KMPT, Dr. Umo contributes to both inpatient care management and psychiatric training programs. His responsibilities extend beyond direct patient care to include ensuring that training placements comply with the professional and educational standards established by the General Medical Council and the Royal College of Psychiatrists. Ladies and gentlemen, please join me in giving a welcome to Dr. Ekwere George Umo.
Thank you so much for the warm welcome. I highly appreciate it. And I hope you can hear me. I think there is a bit of lag. So if I sound a bit, if my voice trembles, that's because of the lag in the system, what we call glitch over here. So it's unexpected. But thank you so much, everyone, for spending your afternoon to listen to me. And I want to thank the organizers of the program, Professor Bennis, who has made contact with me before this day. And equally, everyone I didn't hear most of the names at the beginning of the introduction because of the lag. But again, I observe all protocols that are in existence so far. And it also plays a warm welcome to Professor Adebayo, who was my classmate, and we graduated together in the same school, College of Medicine. Thank you so much. And to you students, I think it's a very opportune time for you, and you are in a great institution, I can assure you. If all, I still have contact with IFE graduates who have come over to the UK to work in my sector, and they still tell me a lot about the institution, and those who have recently graduated as well. And my first question to them when I hear any graduate over the years is, does the old Booker still exist? So I don't know if it's still there, but it used to be where we used to have great meals and great sessions in the past, but I don't know if great Booker still exists. But back to the presentation today. I just want to see if I can share my slide with you. I'll attempt to share my slide and say, um, so this is the slide of what I'm presenting today, which I'm trying. Sometimes it gets difficult to do the slideshow. Is it possible to know if I'm still being heard, or is that possible? Am I still being heard? Any feedback? Can you hear me? A thumbs up will be good if you can. I can see the students, but if you can hear me and you can see the slide, if you just give me a thumbs up, then I know I can hear me.
Hello, sir.
Yes.
Can hear you, sir.
Okay, you can hear it. And is the slide visible?
Yes, sir. Very visible.
Okay, thank you. Thank you so much. So approach from the beginning of the slide. Okay, so this is the beginning of the start, mental health among healthcare professionals. So healthcare professionals, these are the challenges that we have overall. What is the current global context of mental health disorder among the general population, then the healthcare professionals as well? What's the scale of the mental health burden, the root causes and systemic challenges that we all face, and the impact on healthcare workers, and then evidence-based intervention over the course of time. Then I also have, before the end of the slide, I also talk about emerging concepts of what we all experience in mental health, especially with our years of training and being faced with situations where we are unable to deliver care because of the structures that are available, structures that are currently unavailable to help us deliver the care that we intend to, and which is the concept of what is called moral injury. You'll be hearing more of that in recent times and years to come. So what do we see when we look at the global picture of mental health problem? So far, it's estimated that you have about 400 million people with mental illness in the whole world. Conservative figure, you will say, but that's roughly about what it is. About 400 million people or 450 million globally suffer from one mental disorder or the other. But the good thing is that most of those people suffer from general mental illness rather than severe mental illness. So when you talk about general mental illness, you talk about anxiety, depression, mainly anxiety and depression. So it's stated that about 25% of health workers reported to suffer from anxiety and depression and burnout. 50-60% to 70% experience burnout, especially during the peak period of COVID. Again, COVID helped the period before COVID and during COVID and after COVID, there were great mental health crises all over the world. And it's also a time to reset mental health services and how mental health services is delivered. So next slide. So what do we see? Pre-pandemic, there are about 30.4% of people, but suddenly after the pandemic, we have over 46% of people experiencing burnout, especially among healthcare workers in the United States. And about 44% intended to seek new roles. They wanted to leave their healthcare profession to seek other opportunities away because of what was the experience during COVID. There's a recent study done in France which states that about 1 in 5 medical workers want to leave their work profession to find other opportunities because of what they were experiencing at work. That's quite a high figure. So we know that 26% of USF were provided unmet health. There were harassment at work, more than double after the incident. Long COVID independently associated with higher burnout, anxiety, and depression in healthcare workers. So only 20% of people were affected with burnout or mental health symptoms during COVID actually sought help. The peak burnout period was in 2022, which was about 39% of people. So what is the patient-doctor ratio in Nigeria? You have 1 doctor to 3,474 patients. That's generally not mental health alone. But the WHO recommendation is that we have 1 to 600. Equally similar figures apply for nurses, dentists, and other healthcare professionals who equally are important in the scheme of things, delivery of healthcare. So the mental health burden among Nigerian healthcare workers, depression stacks about 31%, anxiety symptoms about 30%, severe psychological distress about 6%, and moderate psychological distress accounts for a larger amount of the picture. But I just want you to, when you hold this picture in mind, we're talking about mental illness that is not as severe in the severe spectrum. So when we talk about severe spectrum, we're talking about schizophrenia, bipolar affective disorder, or chronic PTSD. Those ones are not accounted for in this picture, in this current picture. So I just keep those aside because it's better to talk about the commonly occurring conditions first before you talk about things that are on the extreme end of things. So what about students generally? Students, about 25% psychiatric morbidity in the student population worldwide. But overall, these pictures are comparable to these figures are comparable to what you have even in the United Kingdom. And I know this because I'm an undergraduate faculty lead for King's College University, and I was also an associate role with University of Grenada, looking after the undergraduate students who came for medical posting placement in the United Kingdom. So these are quite significant figures to look at. We have 14.8% suicidal ideations among students. And then again, this figure ranges from 14% to about 60%, depending on if the person had previous mental health conditions before they started school. About 22% suffer from psychiatric disorder in private universities. So the key thing we want to talk about now is more about burnout. So you know the dimensions of burnout. Burnout has been something we've been studying since the 70s. So I just want you to relate this to what you have in the student population as well as healthcare populations. So burnout consists of 3 things: emotional exhaustion, depersonalization, and reduced personal accomplishment. The feeling of being drained emotionally after work. I remember the intro given by Professor Bennis, which talked about the long hours of work that health professionals have to endure. And then coming back at the end of the day, how stressed you are. That's what you feel, the emotional exhaustion, not feeling that you have given everything you need to give and having nothing else for your family and dear ones at home. So depersonalization is, you just start, suddenly that creeps in when people start feeling, what's the point of doing this job? They see this because they see no joy in doing it anymore because of the burnout. And burnout arises from chronic stress at work. It's either the stress you experience of not being able to deliver the care about you were meant to deliver, or because of the amount of demand the system places on you, and you have to keep giving. So that leads to something what is called reduced personal accomplishment. So you just feel at the end that you've not achieved anything in your career or what you have been on your day's job, and you feel frustrated about it. But the key one you want to hold on I want you to look at is the depersonalization. When people start having negative feelings towards patients, especially, that's a sign of a burnout, when you just suddenly feel that the person you're meant to look after is draining you, or you have these negative emotions towards them. That comes through burnout. So the other thing we talk about in health workers, especially all over the world, especially in the developing world, is violence against health workers. And that violence comes because people are frustrated, either through outcome or in terms of outcome they expected. And equally in places where you have to pay for health care and you do not get the result, that tends to bring resentment and anger towards healthcare workers. So about 52% of healthcare workers experience workplace violence. 61 have 61 this is Nigeria, 61% have witnessed harassment of colleagues, 47 experience psychological violence, and violence perpetrated mostly by patients or relatives. And causes include long waiting times, drug shortages, bed space issues. Verbal abuse is common, and I must tell you that in the United Kingdom, and especially if you work in frontline care, that is something you experience. Even though there's been a national campaign called No Violence, Zero Tolerance to Violence. But at the end of the day, even if a person is violent towards you, all you can do is either to report the incidents, but workers also become frustrated because nothing comes out at the end of it. But that's mainly verbal violence, which is equally important. So stigma and cultural barriers. So this stigma is a key concept in mental health, especially because one, you have what is called a personal stigma, and also a stigma imposed upon you by other people. So the personal stigma comes through one feeling that they are not part of the society, or people have formed opinion about them. And that usually starts from outside. So when you have people who have preconcepts or stereotypical views about people, especially people with mental health problems. And then you also form, through that stereotypical views, you develop attitudes towards them, mainly negative attitudes and the way you see them. And then thirdly, you distance yourself from them. So first and foremost, you have the stereotypical attitude about beliefs about them. Then finally, you distance yourself from them. You want to stay away from them. I must tell you that globally, there's actually no difference at all in terms of these attitudes towards people with mental disorder. So recently, there was a study in Japan which says that student nurses had beliefs of being distant, or had attitudes of being distant towards mental health patients. But the difference in that study was students who had people with mental disorder in their family, or who had prior contact with people with mental health disorder, were less distant from people with mental health disorder. So that there is that concept that when you start to treat people with mental disorder outside the system, you're actually creating a distance. And that distance grows and grows in the people who work in the health service system. So 40% of 20% of Nigerians are affected by mental health issues. 12% suffer from mental health behavior. Majority attribute their mental illness to supernatural causes, witchcraft, and curses. Many seek spiritual intervention rather than medical treatment. And that's also to do with stigma. Stigma because people feel more accepted in their close society where they belong, their home. But always let's remember that when we talk about these figures in Nigeria, most mental health care occur in the community and in families than in hospital. We don't have enough hospitals anywhere in the world to treat people with mental health problems. Most care takes place in the community, but that also creates a bit of burden for people who are less resourced. So among health professions, there's higher stigma among pharmacists, doctors versus nurses. Male professionals show higher stigmatizing attitudes. Again, these are from studies that we've seen, but again, these studies might also be biased because of the population that we are taken from. I think globally, all over the world, you still have the ratio of nurses to doctors. There are more nurses than doctors, and vice versa. And equally more female healthcare professionals than healthcare professionals. Those without contact stigmatized, more reluctance to seek help seen as a weakness or failure, fear of carers, consequences discourage disclosure. So the other thing that was found in terms of global figures among healthcare workers is that healthcare workers tend not to seek help on time, and mainly men don't seek help both on time, both for physical and mental health problems when they occur. Hence, again, if you look at the parity of esteem, so if you want to equate the treatment of mental illness and physical illness together, men tend to seek help later for cancer than women. Women tend to get diagnosed early and have better outcomes, but men tend to seek help later. So I'm just trying to emphasize that this is not just this health-seeking behavior is not only in mental health, but also in physical health. So what do we see? Psychiatrists, there's global shortage of psychiatrists all over the world, but Nigeria's problem is quite probably more acute in this sense, or not just Nigeria problem, but sub-Saharan Africa. I think this is a figure from Association of Psychiatrists in Nigeria, which states there are about 198 psychiatrists in Nigeria. I guess the figures may have improved, but these were figures bounded around as far as 2018. So, but what's happening? We know that people get to leave Nigeria health service for various reasons, and some people do remain for various reasons equally. But if you can imagine a population of 200 million people, so you're basically saying there are about one psychiatrist to 1 million Nigerians. That cannot deliver in any system. That creates more demand for any kind of health service to cope with. So what are the systemic challenges? Because you cannot change things, sometimes change starts, although we say from ground up, but sometimes it's better to do it from up down. So we have inadequate infrastructures, we have less hospitals and chronic shortage of equipment. There's chronic understaffing, there's poor remuneration, we know that. And hence we have industrial actions because people are demanding the right pay for the job they are doing. We also have unsafe conditions, especially because people have to work long hours, and not just the long hours, but the time of commuting from their home to where they work, especially those who work in urban centers have to live farther away from where they work because of the wages and the rent and all those things. So we have limited career growth. So where do people go? What are the opportunities available? And then critically, there is no wellness support. I guess again, these are things I've read from papers, but I wouldn't say they're entirely what operates where you are. But from my point where I am now, like I said, I have connections in as undergraduate faculty lead where I am. We have various support programs for students. We have various support programs for healthcare workers, including well-being groups, access to psychological therapies, because not all mental illness need treatment with medication. Some just need some psychological therapies available. But again, I don't want you to take it that things are quite rosy down here. No, the average waiting time for psychological therapies in the UK for common occurring problems is about 3 months. So you still have to wait 3 months before you have psychological therapies. But there are some quick wins in terms of there are online psychological therapies available in the system. So you can have an online CBT, and which is has been randomized control trial has been carried out, which is effective for anxiety disorder and things like simple phobia. So impact on patient care and safety, we have long wait times, reduced care quality due to burnout, increased mortality, again, test delays and rural abandonment. We know that most care is provided in the urban centers than in the communities. So this is a concept that came out more after COVID, because after COVID, we all had to go back to working remotely. And then most people are stuck with this remote work now that they spend most of their time on screen. And then this is something that happens now that is common among healthcare workers all over the world. And you can read about them. But also why it's important is it's causing a new concept of social isolation. So where you're not able to see your colleagues at work except on screen. And then that causes a bit of isolation for people who live alone, whose social contact was going to work to see people. And that's also causing a bit of emotional crisis. So what are the evidence-based interventions in terms of what works well? So we talk about peer support programs. So everybody should, at work, should have a peer group. So peer support starts with, for healthcare workers, including mentoring. The mentoring you receive, the people that guide you when you come into a new place of work, because we all come with we all have good reasons for coming to a place to work, but you need some guidance, especially what actually works practically on ground compared with the theoretical concepts you've come with. So you talk about training and providing people with training and education, stress management, resilience training, and building coping capacities. So there was a study that was carried out in the UK. We talked about educating people, educating mental health workers about stigma actually reduces stigma towards patients. And that's been very effective in the sense that over the last 10 years, the Royal College of Psychiatry has spent enormous resources on reducing stigma mental health stigma among professionals and also among the general population, that we've actually seen the trade-off recently that people do not tend to stigmatize mental health patients unlike before. So education works and campaign works. So talking about educating people, the proposal is to have mental health awareness starting early in life. So, for example, as far as primary, secondary school education, to have an awareness. Because when things are invisible, people believe they don't exist, and suddenly they are faced with it in real life. So, counseling sessions, providing counseling sessions for healthcare workers, especially on site when they when they need them in crisis. Relaxation techniques, providing areas and spaces for people to have ability to relax and again, this also involves general system design. So, for example, if University of Ife, I think, is a very great environment to study because of the green large spaces we had in the campuses where people can go and sit down and get their mind refreshed, especially after they've had a long day of work or a long day of study. So those designing cities like that to have open spaces where people can have opportunity to release some of their stress. So recreational activities, getting involved in clubs, associations, sporting activity. In fact, for people who have commonly occurring mental health problems. So, for example, from anxiety to mild depression, the guidelines here states that graded exercise is the first thing you try. So apart from interpersonal therapy, you look at graded exercise before you start giving medication because that works, it's effective. Providing people with information about mental illness also helps. So in terms of overall things, we need to think about reforming the policies overall, advice to government, having having clinicians at the forefront of policy development will tackle a lot of issues in the system. So talking about hours of work, for example, where I work, I can choose to work 4 days a week. I can choose to work 5 days a week. And some of the days, if I want to, I can choose to work from home 2 days a week and then 3 days on site. And everything still runs well. Because again, as in the consulting role, I don't need to be there all the time. Increasing the healthcare budget is important. Implementing competitive pay packages and allowances. Again, this needs to be put in context. Overall, the history workforce research suggests that gets to a place, there's a plateau where increasing wages will not deliver a better outcome or productivity, but we are not yet there yet. That we still need people to have a living wage where they can that can sustain them and sustain their family. Fully implementing the Mental Health Act of the 2021, which has been for a while. I don't think it's been enacted yet. I think also establishing a mental health, Ministry of Mental Health on its own. Sometimes when you need a national driver, it's better to have a minister of state sit at the head of things. Improve mental health awareness in schools, which is very important, and creating bonding agreements to reduce brain drain and engage people who have worked in mental health services in Nigeria, as well as who have living experience of working abroad, to share experiences and the challenges they go through. So what can the institutions do? So what can institutions do? So establishing employees wellness program. I think before that, I'll go to yourselves, especially in people who organize this Preceptorship program, the students. What do you do for your colleagues? What are you doing for your colleague who is under stress? What are you doing to somebody you know of who is going through some problems, emotional problems? What are you doing for them? And I think the biggest thing, the best you can do for them is to listen, to listen. Always have time to listen. Identify the problem and listen to the person. So establishing a wellness program for people, students, and as equally workers in healthcare provision, and enforcing, good work-life balance, and then also creating an avenue for people to speak out, to speak up or speak out, and integrate mental health training into every aspect of healthcare or other things. Because whether the research shows that even people, 20 to 30% of people with physical health problems, depending on their severity, have mental health issues. And the outcome of treatment of a physical health condition, diabetes, cardiovascular disease, and all those is impacted by having a mental health condition. So we need to put this at the forefront of teaching to identify and treat mental health conditions early, and then address work safety, provide people with security at work so that they are not harassed or they are not suffering personal harm. Because it takes just one incident at work to stop people, make people want to leave their profession and never come back to it. So now, before this stage, I'll just tell you of a personal experience, two personal experiences over the course of working in St. Martin's Hospital. That's talking about 15 years now. I've experienced two colleagues take their lives. And then, but this one we never knew had a mental health problem. And then the other, we kind of thought they may have had a mental health problem. And actually, one of them was a psychiatrist who took his own life. I've had students, but I've never, the students, none of them, thankfully, has had any severe incident. But I do come across students who have emotional problems, and then, but what I find out is identifying it early and signposting them to where they can get help, and equally providing liaising with their college to give them opportunities to take a break, because mental health is far more important, I think, than everything else. Their well-being is far more important. So this is my call for action for you guys here is what will you do in the next 24 hours or in the next week to help the cause of mental health, whether it be in your halls of residence, in your faculty, or among the group you study with? How are you going to generate awareness that there is help available? And how are you going to support your colleague when you feel they have mental health problems? Not just, again, secondly, what is in your gift to reduce stigma of mental health in your halls of residence as well as at home? Because studies have shown that stigma doesn't start when people get to school, but actually it starts way back in their home environment. And just to be aware, you are in the prime time of life because 75% of mental illness actually starts between the age of 14 and 25. So that's probably about, probably say the peak age, the average age of students in the university will be between 22 and 25, although sometimes in the developed world it's about 27. So there is mental illness around. If you look deeply, there are people who are suffering from it, and you might just be the person that can help them get out of it. Okay, I think I forgot another thing I wanted to talk about before I close. As I forget, is the issue of moral injury. You will hear a lot about moral injury now because what moral injury comes from the concept of you have trained as health workers, you've had the best training, you have the best experience, and now you come in with a mindset that you want to use all that you've been given to effect change for the positive side to help people, but you're constrained by what is provided to help you. So you can just, you look at it, but you seem powerless and unable to deal with that situation. Then people get morally injured by that. And through that, they get depressed, frustrated, and want to leave because all they have been taught, they can't put it to use. But my call is don't give up. Don't give up. One person can change things, and maybe you are that person. Thank you.
Thank you so much. Thank you so much, Dr. George Uma. We are very grateful for this lecture. Well, we will go to the second lecture, but I just want to give a little bit summary of what George actually told us. He actually mentioned, the burden of mental health globally, and he actually looked at, the issue of COVID-19, the surge of mental illness among the mental health care workers, and he also looked at the Nigerian picture and the workforce crisis in Nigeria and the mental health burden among healthcare workers. In fact, in our study that was done during the COVID period in Ile-Ife too, actually gave a similar picture. And a very important one has to do with the suicidal ideation among healthcare workers. And he also looked at burnout and workplace violence and stigma. Stigma is something that we really need to speak up. We need to talk about it. And he looked at the systemic challenges in healthcare system, where we look at the reduction in the infrastructures and also to the poor support system. And he talked about computer vision syndrome. Well, we also need to, we mentioned evidence-based intervention, which include peer support programs, psychoeducation, relaxation technique, and information resources. And there are recommendations, policy recommendations in terms of workforce protection and system strengthening. And what can institutions do? Increase employee wellness and address workplace safety, integrate mental health into training, and safe report channels and humane work schedule. Now, the call for action. I think, in the next 24 hours, can you decide to talk, about mental health to someone? And can you also try as much as possible to reduce, stigma and let you know that, there is help and we can all, talk about it. So thank you very much. At this point in time, I would like to invite Dr. Oladokun to the high table.
Thank you very much, Professor Akinsolori. Without wasting our time, we are moving straight to the second person that will be doing justice. So that is in person of Professor Charles Dike. To read his citation, we have
Good day to the Provost. All protocols duly observed. Good day, everyone. I'll be reading the citation of Professor Charles Dike. Charles C. Dike is a professor of psychiatry, co-director of the Public Psychiatry Division, and deputy chair for state affairs, Yale University School of Medicine. He is also chief executive officer, Connecticut Mental Health Center. Prior to that, he was chief medical officer, Office of the Commissioner, Connecticut Department of Mental Health and Addiction Services, and past president of the American Academy of Psychiatry and the Law, AAPL. Dr. Dike completed medical school at Obafemi Awolowo University, Ile-Ife, Nigeria, and psychiatry residency at All Birmingham Hospital Psychiatry Residency Training Scheme, attached to the University of Birmingham, England. After additional training at the University of Illinois at Chicago, Dr. Dike completed a fellowship training in law and psychiatry at Yale University School of Medicine. Dr. Dike obtained a diploma of clinical psychiatry from the Royal College of Physicians and Surgeons of Ireland and was awarded a membership of the Royal College of Psychiatrists of England in 1998. He obtained a Master of Public Health degree from the University of Illinois at Chicago in 2004 and a Master of Arts from Yale in 2024. A past president of Connecticut Psychiatrist Society and co-founder and past president of Nigerian American Psychiatrist Association, Dr. Dike is a distinguished fellow of American Psychiatric Association, fellow of the Royal College of Psychiatrists of England, and fellow of the American College of Healthcare Services. He is also past chair of the Ethics Committee of the APA and of the AAPL, and author of Ethics Corner in Psychiatry News, a monthly article discussing psychiatry and medical ethics concerns in practice. Dr. Dike is a special government employee serving on the National Advisory Council of the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, SAMHSA. The American Academy of Psychiatry and Law established the Charles C. Dike Scholarship Award for his tireless work on diversity and inclusion and other issues pertinent to forensic psychiatry practice. He is also a recent awardee of the APA's Chesterpiece MD Human Rights Award. His interests include, but are not limited to, medical and psychiatric ethics, pathological lying, management of abortion, health systems administration, and forensic psychiatric consultations, civil and criminal. Ladies and gentlemen, please give it up for Professor Charles T. Dike.
You can speak now, Professor Charles Dike. Please speak on. Thank you. You are welcome.
Okay, thank you so much for the wonderful introduction, and thank you for inviting me to this fantastic event. I am extremely privileged to be here today because Madam Provost was my classmate in medical school, along with her, dear husband, Professor Yinka Adibengwe, who we also used to call Iwe. So I think that 30 minutes is not enough time to describe all of what we're going through in school and the fantastic times we had. And it's not enough time to actually describe this topic as much. So I'm going to try to cover as much as possible, knowing that there is still going to be more. But I also want to commend the previous speakers who have already touched on most of the issues. So this is going to be a review to many of you because they have already been addressed by your wonderful lecturers. But I am just going to go ahead and do that anyway. All right. Let's see. Okay, let's get going. So I'm decided to take a shortcut and just do physician wellness, burnout, and suicide. I know we have a whole lot going on today, so I'm going to just rush through some of this. I'm looking at the time as well. Now, everyone knows that doctors are under tremendous pressure. I mean, this is a physician, but actually all healthcare practitioners are under tremendous pressure, but especially doctors, since that is what we're talking about today. And it's all over the world. And their reasons are different depending on where you are. For example, in the US, it might have to do with, the ease of being sued, just amount of paperwork you have to do to prevent that, which is extremely overwhelming. In Nigerian context, there's a whole lot of reasons. We're going to get into some of them in a minute. But bottom line, doctors are under tremendous stress and pressure. It's not very common to see things like this in the newspapers in Nigeria. When we were in training, I think a million years ago, nobody talked about suicide or serious mental health issues in Nigeria. It seemed like what happened to those Oyibos is far away. But now look at it. Every single corner you look is dramatic stories of suicide and suicide attempts. One that was really striking to me was this individual who calmly walked to the bridge with his driver, came out of the car and plunged into the water. I mean, that was quite dramatic. But in fact, jumping off the bridge to commit suicide is very common. And the commonest bridge that was known for suicide was the Golden Gate Bridge, where up to between 30 and 41 individuals jumped from the Golden Gate Bridge in San Francisco to commit suicide. And until 2024, when they put some kind of resistance so that it dropped dramatically from 30 per year to about 8 or 4 per year. But the fact is, these are dramatic stories that are happening everywhere. And it has come home. It has come home to Nigeria. The rates of substance use problems are huge now all over the country, in the north and south and everywhere. Mental health problems are just normal. So things are really crazy. But the similar difficulties we have in Nigeria is what we have in the US as well. It is very clear that doctors or physicians have one of the highest suicide rates amongst other professions. And you can see that for male physicians, 40 times higher than regular generation. But look at for females, much, much, much higher in women than in men per the general population. An average of 10% of physicians, imagine that's a huge number, have suicidal thoughts. That's a lot. One doctor dies per day by suicide here in the US, which is absolutely crazy when you think about it. Now, the specialties that are most affected sometimes depend on the period of the study. For example, right after COVID or around the time of COVID, pathologists, general surgeons, infectious disease specialists had significantly high rates of suicide. And you can imagine, I can go into all the reasons if we had time, but I think you can imagine that was a significantly heavy time. For surgeons, first, there was nobody coming in, so that was a problem. And then when they started to come, they were overwhelmed with all the backlog of work and so on. It was quite a time. But, I think consistently, these other specialties have been known to be relatively high to have relatively high suicidal rates. Anesthesiologists, psychiatry, emergency medicine, general surgery. Now, I can also go into the reasons why they are commoner in these specialties. But I don't think, if we had time later on, I can go into some of it. And obviously, access to the means of committing suicide also makes it easier for that to happen. But let's talk a little bit about women. Why is it much, much higher in women than than men? And this is quite different from what usually happens in non-physicians, in general public, where women, although have higher suicidal thoughts, suicidal attempts, they actually have lesser completed suicides than men. However, in women physicians, it's reversed completely, and it's not difficult to understand why. You look at the responsibilities at home. Women still have to come back, take care of children, cook, clean, and all the other things that they are expected to do, in addition to working really long and stressful hours. my colleagues and I were writing an article on Nigerian men killing their wives in the US. And this was very prevalent as well. The women would come home from long work hours, double shifts, and the man would still expect them to do everything, cook, clean, and they become abusive to them, and ultimately it becomes so overwhelming that it's not difficult to understand why somebody might decide to take their life. So this is very difficult. Now, this is also in addition to the fact that they are going into work every day that is dominated by men, and they have to prove themselves over and over again because everyone says, what does the woman know? I want to see the male doctor. So they have to always prove themselves over and over again. That's quite a difficult thing. And this is why the prevalence or the risk of female doctors committing suicide is very high. I'm highlighting this so that we can be very gentle to our sisters. And, when we see and we know what they're going through, both at work, at home, and everywhere, we can extend grace to them when we see them struggling. Now, I'm just going to talk briefly about some of the sources of stress here in the country. Nothing I'm going to say here is going to be news to anybody. So please bear with me if it sounds really, really, very simple. Bear with me if it sounds that way. But I think it's what everyone knows, that doctors experience, as much stress in the country as others, but nobody believes that doctors do. Everyone thinks, oh, doctors' lives are better. They are above all of that. The society expects you to be extremely rich. You're already rich by saying you're a doctor. Hence, everyone, their mother, their father, grandmother, everyone, uncles, they're all reaching out for handouts. And you can imagine how stressful that can be. Your family members and extended family members and villagers, communities all expect you to meet their financial needs. Everyone is looking to see what kind of house you live in, what type of cars are you driving, where are your children going to school. And the society expects all of this to be completely at the top. In fact, while I was working in Lagos before I went to England, one of the patients who came to me was saying that she would never see any doctor who doesn't drive a Mercedes-Benz or some other highfalutin car because, I don't want to see a doctor who drives a Jaguar. So in other words, affluence is associated with competence, and therefore you can imagine the pressure this also imposes on doctors. Obviously, as I said before, there are lots of expectations, obligations from your village, and so on and so forth. So the pressure from society alone is immense. And now what about the pressure that medical students on medical students? First is the self-imposed worry. Everyone who goes into medical school is almost like a type A personality. We are, harder on ourselves than anybody else. We blame ourselves, excessive guilt. We want to make sure that we are performing at the best of everything. And therefore that puts us on tension all the time because we are holding ourselves to the highest of standards, which we should, but sometimes it goes beyond normal. In addition, even as medical students, many medical students are carrying the weight of expectations. Some of them are actually supporting their families at home. Everyone has all their hopes on this one person. So it's very difficult to be the one who's shouldering all of that. And then in terms of lecturers and teachers, listen, we love our teachers. We love them. We revere them. We praise them everywhere when we gather together. But some of us, I'm telling you, still carry some of the traumas of some of our teachers. We have public shaming, verbal and psychological abuse, which happens in front of your peers, in front of nurses and patients. Some of us experience that. And for some people, they still carry that trauma, despite still holding our lecturers in the highest regard. Now, our generation could handle that easily. But I bet you this current generation, and my children are from this generation, so I'm not trying to blame anyone. This current generation do not really respond well to that type of teaching or that type of shaming or public or verbal abuse. And so it carries much more weight with them than it does others. And I know what I'm talking about because I've had to counsel some young Nigerian, Ghanaians, medical students who are going through some of these things, very mild in this country, and they're all still shaking. And so this is something we need to pay attention to. The other thing that I think causes a lot of difficulty for all of us is this unstated dangerous ethos of medicine, where we say that the doctor should be tough. Those days we had to wear our toughness as a badge. You work 72 hours straight on call, Friday, Saturday, Sunday, and Monday till, in fact, more than 72 hours without complaining. You must not complain, because complaining is a sign of weakness. You've got to be tough, right? It can't show sign of weakness. You dare not talk about feeling overwhelmed, anxious, or depressed. That's a sign of weakness. Nobody wants to hear that. You dare not ask for breaks or ask for accommodation, reconsideration of work hours. You dare not ask for any of that, because that would be seen as a sign of weakness. I'm so glad that the previous speaker mentioned something about reconsideration of workload and all that. But people, even then, I think medical students will be hard pressed to go to ask for this, because they don't want to be seen as weak. And any sign of weakness must be avoided at all costs, to the detriment of the medical student who has to bear all these burdens hidden inside them. This is a real problem. What about the practicing physicians? Obviously the same thing. We are perfectionists. We have excessive sense of responsibility, exaggerated sense of duty. We're practicing, obviously. The biggest challenge also in Nigeria is, despite all of that, the physicians have to practice with marked resource limitations. I can't imagine how painful it is, or it must be, to watch people die, whom you could save. You've been trained, you have the skills. You can't save them because you don't have the basic resources. That is extremely stressful, extremely difficult, and difficult to manage and to swallow sometimes. So doctors here in Nigeria are expected to work excessive hours with minimal rest to meet all those competing demands I mentioned in the context of poor remuneration, poor compensation by government, unstable and unpredictable government rules. And so, in addition, in order to be able to meet even some of those demands, these doctors will have to work multiple jobs to meet multiple obligations. I am not talking from theory, because I did practice for a few years before I left for England, and I know it's worse now than it was when actually I was practicing. So you can imagine how tough that is. And then all of this leads to a feeling of inadequacy, of being a failure. When somebody comes to ask you about something and you say, I can't do it. Your family member, your friend, your child, you can't pay school fees, you can't. This leads to a significant feeling of inadequacy and failure, which all boils in and becomes very difficult. So the pressure builds and builds and builds. You can see the pressure is expanding, and then the pressure cracks, the individual cracks, and finally explodes. This is what is going on. This is the underground, the underbelly of how things get to a place where you have a breakdown that is very difficult. And so what we need to do, we need to find ways to release the pressure before it's too late. To release the pressure before it's too late. But I also want to mention, this is really an important, Dodson's curve, performance on the y-axis and anxiety on the x-axis. Everyone here is familiar with this. So bear with me as I continue to just do a review of what you already know. Like, we need anxiety. We need anxiety to perform, right? Because with limited anxiety, look at our performance is zero. And, we feel like we are laid back. We don't know what we're doing, little stress. But the more we have anxiety and stress, the more our performance, but up to a point. So there's a point of optimal performance based on stress. Thereafter, if there's more stress, our performance begins to decline continuously, gradually, until the anxiety, we get overwhelmed by anxiety and we have a mental breakdown and have this burnout thing. So it's absolutely crucial that we remain conscious of the fact that we need anxiety. And most of us perform well under pressure. But you also need to know yourself so that you know when the anxiety is more than normal. And that's part of self-discovery. That's going to help you, save you from a lot of difficulties. All right. So in 2018, my colleague, my senior in medical school, Great Ife, Dr. Williams, who most of you might know, and I, and one of our colleagues here in the US, we were tasked with doing a mental wellness survey of the Association of Nigerian Physicians in the Americas at their board retreat. Now, what was driving this? There had been 2 or 3 serious suicides amongst our colleagues in the US, one of whom was our classmate, my classmate, which broke our hearts. but there had been 2 or 3. And in fact, the other was a man who was married to another great Ife alum. So this is a big deal. And we were thinking about, what's going on. So the board of AMPA, Association of Nigerian Physicians in the Americas, wanted us to address this. And so we did a survey, a stress survey. And I'm just going to give you some, I don't want to get into all of it as we, because of time. But you can see the survey, to start, we just defined a few things for them. That, physician burnout, we define it as emotional exhaustion, interpersonal disengagement, and low sense of personal accomplishment. In other words, no matter how much you're accomplishing, you feel like you're not doing anything. You feel disengaged with work. You're going to work already, dreading going to work. You're feeling terrible. You're not enjoying what you're doing. You feel exhausted. That's the kind of burnout. And there's a map that leads to that level when stress, overwhelms you to that point. And so we were also trying to highlight what we wanted them to embrace, which is a culture of wellness. And we define that as a set of normative values, attitudes, and behaviors that promote self-care, personal and professional growth, and compassion for colleagues, for patients, and for ourselves. Ourselves is really important. And so we also wanted to just highlight a couple of things to these individuals related stress. And we said persistent stress, obviously, all the stressful things I just mentioned can lead to anxiety, can lead to depression. And, a high number of male doctors have anxiety, and even a higher number of female doctors have anxiety and depression, which is not surprising because women generally have more depression and anxiety than men. But as I said, in female physicians, when it comes to suicide, it's reversed. Right. Now, what about medical students? Up to 30% of medical students have high symptoms of depression. This is a highly stressful vocation, and in training is extremely difficult. Suicide, in fact, at least in the US, is the second most cause of death amongst medical students. Second, which is a really big deal. Now, this is annoying and crazy and terrible because depression and other mental health problems that cause suicide are treatable, right? They are manageable and treatable. But my previous speaker had already mentioned stigma as one of the major issues that makes it difficult for people to seek care. So this is it. Now, what are the findings? What did we find from our stress survey amongst the AMPA board members? We found that many of them were laboring under significant stressors. They listed all of them down there. And we also found that a sizable number of these physicians actually had signs of depression. I mean, they're going around working, like it's a working, working sick, how do you say it now? They're going around working, doing their daily job, but they're showing signs of depression. This is a sizable number of, physicians at the top level of their game because the board members of AMPA are at the top level of their game. A small number actually had responses that suggested suicidal thoughts, which alarmed us to no end. Now, luckily for us and luckily for them, they also had significant protective factors against suicide. So we had to make sure that there was that balance, and the protective factors, counterbalanced the suggestive suicidal thoughts. But what we learned from that made us decide to develop a wellness subcommittee for the Association of Nigerian Physicians in the Americas to be a professional resource for members who might be struggling, at least to direct them, to advise them, to provide a point of how they can proceed with things. So that was just a survey to tell you that this is a big deal amongst Nigerians in Nigeria and amongst Nigerians abroad. Obviously, the pressure for Nigerians abroad is also, I know people might think, yes, you have financial resources, but let me tell you, the pressure is immense from home. I'm telling you, it's a lot. And so it becomes a really big deal of trying, how do you manage all of that? Now, what are the things that might predispose an individual to mental health breakdown? These are, again, you guys know all of this, but I'm just listing them for completeness sake. Biological factors, anything that has to do with genetics or major medical problems, chronic medical problems, chronic pain, medications, all of those things can predispose you. Psychological depends on your environment. We just mentioned all of the stress, social environment, even spiritual can cause mental health breakdown, and I can get down to the spiritual practices. Let me see if I have it written down somewhere, because I want to make sure that I mention some of the spiritual practices that can lead to a mental health breakdown. But one thing that is often overlooked is childhood trauma. A lot of people who are coming in, who you see as adults, you just don't know what their histories are. Many people have suffered significant trauma in childhood, and those things have affected them in their adulthood. So this was discovered by this individual, Dr. Fellini, who is actually an internist, who surveyed so many different adults and looked at 7 categories of childhood exposure to trauma, really, and found a strong relationship between the number of childhood exposures to trauma with future mental health and disease problems. And the impact of this actually can be cumulative. In other words, the more the trauma, the more the chances of you having. And here are some of the trauma things in childhood before age 18. And I put this out here so you know for yourself that if this is something that happened, you understand that you need to be on the alert. So sexual abuse before 18, emotional abuse by one parent or any loved person, physical abuse by a parent or a loved person, actually physical abuse between parents, that you're seeing one parent, fight the other, emotional neglect, abandonment, witnessed physical abuse of a loved one. So all of these things are predisposing vulnerability factors that can make you, prone to developing a breakdown from stress. So if you add significant stress to someone who's already laboring with this or having the background of this, you can imagine how they might break down. Now, I just want to mention, though, that just because you have one or multiple of these ACEs, it does not mean that you will develop any mental health difficulties. No, it doesn't. All it does is that you should be on the alert, right? With intense stress, some of those who are predisposed might ultimately break down, but that doesn't mean that you will. So just be mindful of that. All right, so this is where I had put this before. I talked about other predisposing. I think those are all there. But obviously, drugs and alcohol is a huge thing these days, right? Genetic predisposition. Many of us don't even know whether our grandfather had any mental health problems or not, our grandmother or members of our family. Someone like me who grew up in Lagos and all my family is in the East. I mean, I would not know what's going on with them. But there's a genetic predisposition, the environmental stress, social isolation, which is terrible these days, where all young people are, in fact, people don't talk to each other anymore. They're just on their phones. I think Nigeria might be better. I hope Nigeria might be better than over here, because it's a real struggle. And so people are in their heads. It's difficult. They're being swayed by all the nonsense they see on social media, most of which are lies anyway, but people don't know, and it affects them negatively. So that people are really in significant mental health decline, which is why countries that are smart are banning cell phones and things from children until at least they reach 18 or 21, because this is a big deal. It's one of the commonest causes of significant mental health handicap for our children and young people these days, and that includes people of medical school age. Now, the unhealthy spiritual practices that might also be associated with breakdown, as you can see, enforcing behavior. Sometimes people tell me, I don't need to take treatment. One of the guys I saw, there was a time I used to work for Shoreline Christian Counseling as their physician there. And one of these brilliant artists who's a Nigerian, studying his master's at Yale, came and said, and I think he has bipolar disorder. He knows he had bipolar disorder, but a pastor had passed by, put his hand on his head, prayed for him, and told him he was going to be well. And so he thought he didn't need anything. He didn't need medications. He wasn't taking it because, somebody had prayed for me. That's a problem, because, again, treatment should include all of them, not exclude one because of one thing or the other. That does not mean that God cannot heal you completely. God can, and He does. Absolutely. I know. I have been and experienced that. God can heal you completely. But please, there are practices that can also be problematic. And so receiving treatment or seeing psychiatrists, you have all this shame because maybe there's a demon that's inside you that's making you have all these problems. And it's very difficult. Passive, coping. Somebody's been abused by their husband and, and you say, well, it's your husband, wife must be. No, you have to confront it and address it, because this is not justification for causing significant harm to your wife and children. So again, I'm a highly spiritual person. I thank God for where I am. I thank God for blessing me continuously. But I also know that we have to be very mindful of how individuals can misuse these blessings and this knowledge in a way that can be detrimental to the mental health of our colleagues and our patients. So just be mindful of that. So let me rush through. I'm looking at the time, machine is running. Let me rush through some of these medical strategies. I think, again, nothing new. But I want to use like a public health approach to this, because this is now a public health issue. It is not longer an individual issue. It's a societal issue. It's a countrywide issue. So let's use our usual, primary health way to look at it. One is, I think the most important thing is you need to know yourself. You need to know your body. You are not the same as me. I am not the same as you. I might do well with 5 hours of sleep. You need 10 hours. You do what you know your body needs, right? And your body's clock will tell you when you need to rest. Don't ignore it and push it and say, okay, you might ignore it for a day or two, but please make sure that you get back to taking care of yourself. Self-care is so important, because without self-care, how can you care for others? You've got to be healthy in mind and body to be the best doctor that you can be for the patients who are coming to you for help. Therefore, self-care is important. Obviously, screening, and we can talk a little bit about that, teaching self-management, modified workload. But here just kind of a lifestyle supporting mental health activity. So physical activity is very helpful. You release endorphins, which help, manage emotional health. You avoid harmful substances, alcohol, drugs, marijuana, just avoid them. I guess people, you might take one or two and be fine, but I say just avoid them, because there's no benefit. So why take them? Social connections are huge. And I mean, positive social connections. They're huge. Sleep is amazing. There's diet and nutrition there. Each time I see diet and nutrition, I laugh, because some of us when we were in medical school, it was 101 or 001 or 1 or 010. So yeah, it's difficult to completely get the diet and nutrition, but at least you get the picture. Self-care. Do what you need to make sure that you are good. And these things will help you. Obviously, secondary, early identification and prompt treatment. Again, I'm just rehashing some of what we all learned, what you guys are learning now, because it's really important to be treated promptly, especially for mental health challenges, because it's important so that you can return back quickly to health and obligations. You can avoid complications. It doesn't get so far that things have, so much has gone under the bridge that the next thing is suicide. But the most important also is the longer it takes to be on treatment, the more difficult it is to treat. The more refractory it gets, the more challenging it gets. So it's just better to get there. Obviously, the challenge is stigma, right? Which prevents people from seeking help. Cultural taboos around mental health, discrimination. Oh my God, that their family, they have issues in their family, shame, embarrassment of seeking help. Those things make it very difficult. But on a systemic level, this is both a primary and a secondary prevention I put here together. Apart from beyond the individual, the system needs to do a little bit more. There has to be comprehensive wellness programs to emphasize the importance of holistic health. Balancing, right? You have to balance academic success and stress and stuff with social, with physical well-being, through making sure you have time for fitness programs, relaxation techniques, stress relaxation. Some of us did more of the fitness than studying when we were in school. I thank God we passed. But, still we have to sort of balance the two of them. Resources are difficult, because we know that we don't have many therapists. We don't have the numbers of therapists, psychologists, social workers, psychiatrists in Nigeria. I have all those numbers by 230 million. They're very little. But these days we can do virtual counseling, which might be easier because, people are not moving around. You can find ways to do that. And peer counseling is also really good. Obviously, my previous speaker had talked about integrating comprehensive education on mental health and wellness in curricula around the school. Nobody should leave the school without having gone through something that talks about mental health, mental wellness, and things you need to do to avoid mental difficulties. Many countries or many systems are now having this buddy system where you have peer mentors and people listen more to their peers than they listen to supervisors. So they are using that as a way to get at people. Obviously, treatment also is biological, psychological, social, and spiritual. These are all treatment modalities. Biological is investigations, medications, all of that. Psychological is counseling, therapy. Supportive counseling is huge. Just a support, just a listening ear. Somebody who heard you, who says, I'm so sorry. Oh my God. Even that alone, I kid you not, goes a long way in solving people's emotional distress. And, social, I talked about that. Spiritual practices are huge. The literature on those who partake in regular spiritual practices and mental health, the literature is now absolutely amazing. I give a talk on this all the time. So those who are involved in this have better mental health services, better recovery, they're happier, all of that. Just be mindful of what I said before in terms of the negatives sometimes. I'm not going to talk about tertiary, that's admission treatment, all that stuff, maintenance therapy, careful attention to stressors. I think my time is up, so I'm going to end with this part in words. It's really, as I said before, treating others. Start with treating yourself. You got to treat yourself. You've got to be kind to yourself. We are too hard on ourselves. Any small mistake, we think the world is coming to an end. Now that I'm old, I can look back and say, that's not true. Not so. But, be kind to yourself. Extend grace to yourself. Forgive yourself when you make mistakes or things go wrong. Because let me tell you, you're going to be good. You're going to be okay. Don't put too much of these burdens on yourself. On the other hand, try to be your brother's keeper. We are all in this together. Let me tell you, the friendships you form with your classmates and those above you, they are for life. My class and the class ahead of me, we are like twins. We are in everything together. So be your brother's keeper. Be kind to others. Do for them exactly what you want to do for yourself. All those things I said about extending grace to yourself, forgiving yourself, do that also to your peers and your colleagues and even people around you. A smile and a kind word could make all the difference in someone struggling. And I have an example of somebody who was contemplating suicide, but then ran into a friend who was so kind and, a stranger who was kind and smiling and everything. And that alone averted what was going on with them. Genuinely care about your peers. People know when you care, when you're not being fake. Because there's a lot of fake in school. I know that. But people will know when you really care for them. Reach out to those who seem to be struggling. I know there's competition, right? We want to be better than the next person. All of that is good. But beware of cutthroat competition. I must win at all costs. Therefore, my colleague that is struggling, I can see them struggling. I'm just going to ignore them because I have to go do this. No. You have to, help them struggle. If somebody is acting strangely and now they are different and something is off and you don't see them and you wonder what's going on, please reach out to them. Find out what's going on and try and see how much you can help. Sometimes just being present is all the help they need. You don't need anything else. You don't need to be a magician or have money, or just being present is all they need. And on that note, I'm going to say thank you so much for your attention. And I don't know if we have any time for questions. I don't think we do. But it has been an absolute pleasure for me to be here today and to talk to my junior colleagues. Thank you so much. I'm very grateful.
Okay. Oh, great. So, please, maybe 1 minute, last word, parting word for us.
For the general, these medical students and residents and faculty, consultants, the only passing word I have is, we're all in this together. Life might be tough. Things look difficult. Where you see yourself today is not where you're going to see yourself tomorrow. Nobody in life. I am the last person who ever believed I would be where I am today. I'm telling you, it's just a miracle. So, things can look very dense and difficult right in front of you then, and you think the world is coming to an end. Trust me, it is not. Trust me, you will overcome it. trust me, you will thrive. Trust me, you will succeed. Just hang in there. Just hang in there and focus on all those positive things and avoid the negative things. Please, you will be fine. Thank you.
Thank you so much. Thank you so much. Thank you so much. I think Professor DK actually focused on physicians' wellness, and he looked at suicide, and also delve into doctors under pressure. But I want to let us know that it's not just only doctors that are also under pressures. The nurses, the physiotherapists, and other healthcare workers actually under pressure. So I just see it as doctors as just its own case study that is using to demonstrate to us that we are all under pressure. And the one important thing that is it's disheartening is that the female healthcare workers tend to, it's opposite what we have in the community. They tend to commit suicide, whereas more than the male counterpart. And some of the sources of suicide we look at, one important thing is the societal expectation. People expect that doctors are very rich and you need to do a lot of handouts, and this could be very, very stressful. I could remember that people just come and just tell you that, oh, docky, I need this, and they expect you to just provide it, especially in the middle or the later part of the month. Another one is actually the pressure among medical students. They actually mentioned the type A personality. I must pass. I must do this. I must finish this topic. And this is what could cause a lot of problem. And it actually mentioned the Yankee Dustin's law that look at the performance and stress. And there are other areas, pressure on practicing physician in United States. They actually mentioned a lot about it. And he actually looked at the predisposing factors. And one important thing I want to highlight here is the psycho, biosocial, and spiritual. A lot of people are they shy away from the spiritual aspect of man, and is emphasizing it to us that it's not just biopsychosocial. It's also, we have the biological aspect, we have the social aspect, and we have the psychology as well as the spiritual. And very important, childhood trauma. Now, some of the very important thing is that this childhood trauma could later come to haunt us. And treatment, they actually look at the primary, secondary, and tertiary treatment. I think before I go, very important thing that he mentioned that I would like to read is that number one is that we need to treat others. To treat others, we need to start with treating ourselves. So it's very important. Please treat yourself well. Can you tell your neighbor, treat yourself well? And be kind to yourself. Extend grace to yourself and forgive yourself. Someone will just say that I can never forgive myself. This is an unforgivable excuse. And be your brother's keeper and genuinely care for your peers. Reach out for those who seem to be struggling, and believe. One of the things is this cutthroat competition. I must win at all costs. No, sometimes you win, sometimes you lose, but at the end of the day, we all become the winner. One area that I just want to emphasize is this issue of drug and alcohol, especially in this our own environment, cannabis. A lot of students that we see, there's an increasing rate of cannabis, especially the other, strain of cannabis. We talk about loud, all these ones. This has been increasing in our society. especially among even female students, increased rates of substance use. Thank you very much. If you have your question, we now have the two speakers on. Can you put it on, like the two speakers, can you put them on the panel frame? Let them be on.
Please, while that is going on, I just wanted to say this, and this is what I tell the nursing students. Please speak out. Speak out. You see, there is nobody that is an island or can exist in isolation. And if you think you are the only one that is passing through a particular thing, you might just be wrong. So speak out to somebody that you know will listen. In fact, speaking in itself is therapeutic. So please speak out. Don't hold it in. Don't hold anything in. I'm glad that he focused more on suicide. So people are dying inside silently. Please speak out, no matter how big. If you think it's a mountain, by the time you speak it out, you will realize it's actually not a mountain. And if it's a mountain that you could actually summon. I also want to say that you are not competing with anybody. There is no room for competition. There is no room, absolutely no room for competition. The only person that you have to stand is yourself. You are only competing with yourself to ensure that the standard you set for yourself, you met it. You're not competing with your peers. Stop looking, I must override this, I must come this thing, I must be beyond this person. All those ones are unhealthy competition. Like he said, you will get there. You have a focus, Abby. You have a goal in life, and you get there. It is not. It's not a matter of doing another or overriding another or going beyond another that will take you there. It is a matter of being focused and go through the strength that is proportionate to who you are. We've seen the stress curve. We all need it. I used to tell them that stress is part of life. In fact, without stress, you can't achieve anything. But then we have also seen the other side of it. When you go beyond a particular level, then it becomes counterproductive. Let us take the minimal stress that is enough to put us on our toes to get our goal. And by the grace of God, spiritual. Okay, because I want to say we'll get there in Jesus' name. So if you have questions, whether for Professor Charles, for Dr. Pong, please, you can send it forward if you don't want to ask this. But if you want to ask a question, you can raise up your hand. Just 2 questions for each of them. 2 questions per person. So please. We'll just take number 1, number 2, and then for the other person too, number 1, number 2. Anybody with question? It's all worth taking. Oh, okay. You have questions. So number 1, please come. Okay, number 2. The number 3, somebody raised their hand there, Abby. Okay, number 4, ma. Thank you.
Let's please, can you? Okay. Number 1.
All right. Thank you so much, Ma. Thank you so much, Saz. Okay, so the question I want to ask is for the first speaker. I just want to ask, you were talking about reducing stress and anxiety. So I just want to ask that, is it true that screaming, like just screaming in vain or screaming out in the air can reduce stress and anxiety?
Okay, so thank you. Number 2. Okay, please, can you move out a little bit? Number 2, where are you? Okay.
So my question goes thus. For example, I am someone that any of them. Okay, I will direct it to Mr. Charles. Now, this is how it goes. As it appears, I'm in medical school and I need to succeed. At the same time, I need to create a funding system for myself. Now, the pressure from medical school is enough to spur me to work. At the same time, I want to sponsor myself. No, not like as if my parents are not doing enough, but like I need a situation where my reading and always my studying balance well with how I'm living my life. So, for pressure from medical school, how exactly be able to balance that pressure with the funding system?
So, to Professor Charles is actually talking about study life balance, balancing his academics with his maybe finance. Number 3. Okay. You can stay there.
Good morning, sir. My question goes to Dr. Charles DK. So, we live in a country where people don't really prioritize mental health, but I see that we are creating more awareness for it these days. But then this is still a country whereby you talk to people, tell them that you're feeling overwhelmed, and it's something people easily trivialize. They don't see it as a big issue. When you tell somebody that, oh, I have OCD or I'm dealing with depression, they think you're just overthinking. So I like your advice on how to lay your points to people to make it more believable.
Okay. Thank you. And
thank you, Professor Umo and Professor DK, for a very wonderful time. I think it's Professor DK that mentioned first aid in mental health. We are taught first aid in physical health. What should be your response if you encounter someone that you know is going through an acute mental health episode? How do you quickly take care of the situation?
so she's actually talking about psychological first aid. So that's the question. So I think Professor Charles, over to you.
All right, thank you so much. Really insightful and wonderful questions. So I'll start with the first, where you're talking about the balance. How do you want to support yourself, and at the same time, you want to go through school and you know it's difficult. And this is where I start by saying, know yourself. You really need to know yourself, because you need to know what you can handle, what you can't handle, how much stress you can handle at every point in time. As I said before, I did a lot of sports when I was in Ife. I played, football at the highest level. I did taekwondo to black belt. I also once in a while joined the 4x400 meters, and I had a very active general presence. So I was very active, very busy, in addition to the medical school. The question, though, is how do you balance them? If you remove sports, that extreme stuff that I was doing, and replace it with trying to work and provide some kind of financial support for yourself, along with education, you have to know that it's a balance. It's a balance. Even in academia, I tell some of my junior colleagues who, want to continue to do private practice when they're in academia, and you have to also balance it because there's a need that the academia requires of you, whether it's scholarship, whether it's teaching, education, travel. So if you're doing much more of this, you're not going to do a lot of this and you're not going to get promoted. If you're doing much more of this, you're not going to get this at all. So it's trying to find the balance. And for everybody, it is different. Trust me. That's why you can never look at anybody else. You can get advice from people, seek advice from everyone. Please do that. But then apply it to your own self, your own body, your own system, what you know of yourself. So self-discovery is very important, but it's all about it. It all boils down to how are you able to navigate the balance appropriately. So that's a challenge for all of us, even me. I still continue to figure out how to manage the balance of things. The second is mental health is, I'm sorry, we can't have a back and forth. So I don't know if I have touched on what you're asking for about or not. So please bear with me. I can ask you if that really touched what you're looking for. But in terms of how, we live in a society where people just tell you, pull yourself by your bootstraps and go on, just move on. There's nothing going on with you. You can say things and they just ignore and dismiss what you have. How do you respond to that? I think you have to use wisdom. I think you need to understand that there are certain people who will never get it. There are certain people who are just naysayers. They're going to be terrible no matter what. So the way I would typically approach people generally about this is also going back to, we all are human beings. We have differences. We have differences in how we think, in how we behave, in how we study, in how we respond to life events. We have differences in them. For me, sometimes when something is happening that's serious, this is how I react to it. And then you can bring in some of the symptoms, but not all of it, because you don't want some people to be. Again, it depends on who you trust, right? If it's somebody you trust, you can be more open with everything. If it's a therapist or a peer mentor, you can. But for others, you can be measured in how you present it. You're saying what you're doing, you're saying what you're going through, you're saying it in a way that you're normalizing it. In other words, when I'm confronted by too much work, I have a tendency to behave this way. That's what that's what I'm working on. I'm trying to change it. When I'm confronted with a lot of stress, I have a tendency to have more sort of behaviors that might look like OCD, because I just want to make sure I don't miss anything. So I'm being very particular. And so if you see me, then you might think this is a really serious issue, but that's my own way of dealing with this particular stressful environment I find myself in. So you find ways to use normalizing words to present what you have in a way that I think you yourself will be satisfied. Now, as I said before, you don't, if you're talking to a hater, as we call them, or someone who just is a knucklehead, there's not so much you can say to please them or to convince them. Even then, if you phrase it in the way I just phrased it now, it helps you in a long way, because it makes people see that you're normal. This is your own way of doing things. It might look abnormal to you. I might need help sometimes to even manage those abnormal things or those normal things, but this is my own way of dealing with it. So try to normalize it as much as possible. Again, I'm sorry we don't have a back and forth for me to be able to know if I touched on what you're saying. Psychological first aid is a huge term that has become even more important these days. And I think that it starts really with, first of all what I said before about wellness. It starts with you understanding what things are important, right? What things are important is that you have adequate rest, is that you have adequate sleep, is that you have, time to do enjoyable things, you have social interactions, you have all of that. It's also important to have people you can talk to when you're going through difficult things, who are listening ears, who are, I think this used to be very normal in Nigeria, where we didn't have a lot of mental health challenges because we had so many friends and people we can talk to. Now the world has become insular and people are very difficult. You don't have a lot of such social interactions. If you see someone who's going through an acute psychological distress, first and foremost, your presence alone is enough. Your calming presence, calm words, helping them understand that it's going to be okay, helping them realize that, sort of going through, even some of the, we didn't get into mindfulness, stress management techniques. We didn't get into them, but those are the kinds of things that you can go through with them. Stress management techniques, whether it's deep breathing, whether it's all the other different stress management techniques, whether it's, just trying to help them be present at this point in time. Just, that's the mindfulness techniques. But I think just being a supportive ear and a supportive person, not someone who's going to tell me this is what I should have done or this is what you should do. That's not the time when somebody's going through those heavy things. Even if they did wrong, that's not the time to point out the wrong. This is the time to just be present and supportive and help them calm down and come down from whatever heights they are before you can proceed to the next level. So there are techniques we didn't get into because I didn't think this was the time to get into that. But when we're at the time of COVID, I had a series of lectures for entrepreneurs in Nigeria where we went through all different stress management techniques, to manage yourself when you're going through difficult times. But those are the things that might help somebody at that particular point in time. Thank you very much again.
Thank you very much, Dr. Umar. Any response? Oh, okay. Please. Okay. Okay, please, can you mute your mic, please?
Okay, thank you very much. I think I was struggling because when I tried to unmute myself, the host didn't allow me to unmute. Thank you very much again for the questions. I think thank you very much for Professor Dike. You guys said quite a lot of things there. I think the first participant talked about screaming out. Yeah, that's great. Please do scream out. If you are under stress, in fact, there are some establishments we have in the United Kingdom where there is a screaming out room where you can go out and scream out, you can go out and throw things around, and then as long as you are not hurting anybody. So yes, you can scream out. In fact, when you look at it, if you look at the basis, the underlying thing about the screaming out experience is catharsis. So when you are in church and you are singing, or when you are in the mosque and you are praying and you are shouting, that's the screaming out experience. You are letting out things from within yourself, and that is healing in itself. It's healing in itself. So some people can do it shouting out, some people can do it quietly, and they all achieve the same purpose. And the purpose is to release enough endorphins to go to the frontal part of your head and give you that kind of happiness. So again, the other thing is that Professor Dike was, as mentioned earlier on, diet is important. In fact, our digestive system has more serotonin receptors than the brain itself. So the stomach is the gut is about the second brain you have. If you treat it well, you feel well. So it's not unknown. It's known now that when you take chocolates, the final outcome is to release dopamine in your brain. So that's why people are kind of eat more of that, especially when they are depressed or stressed. And that's it. But I think the other thing is the room hall is now full. So I just want you to take yourself, as we do in mindfulness sometimes, take yourself out of your mind and look at the population in that room. So we're basically saying there are 40% of people with mental illness at any time. So by the time you count 10 people in that room or to your side or in front, at least two to four will have a form of mental disorder, a form of, not disorder, I think a form of mental challenge in a minimal way. So you've got to reach out to these people. You've got to look out for them, reach out to them, and help them to heal in the process. And I think the university is a fantastic place, because I think, if I may recall, we did have a colleague who had some challenge, and the university did help them to graduate. They graduated, and it was fantastic. And it took time, but equally they graduated and they achieved the primary purpose of coming to the university. They graduated, so which is it's fantastic. But I think don't overstress yourself is the key thing. And the other, you're growing up in a generation, you're growing up in a generation now that is so different from ours. So again, I understand your pressures are more than the one we faced. So now the generation you are growing up in and the ones coming after you, the machines are more intelligent than people, or well, they can do computations quicker than people. That's the generation you're growing up in. And now there's evidence that, just like Professor Dike said, there has been an increase in anxiety since 2011 in the general population. Can you guess why that is? I'll save you the hustle. So basically, that was the first time the front-facing camera came to the world. So people are shooting images on internet and everything, but it makes them more self-aware, more self-conscious, and more anxious about who they are. So that it is. But thank you so much for listening. I don't think thank you for listening, and thank you for giving us the opportunity to speak. Thank you so much.
Can we all appreciate Dr. Umar and Professor Dickey for a wonderful time? Thank you so much. Thank you so much. But I just to do this Oliver Twist thing. Please, this is still your college. And whenever we ask you, we just want to, I request that maybe next time we ask you, we hope we oblige us and, just come back and give back to the system. So that is just our simple request. Thank you so much. And today I'll say God bless you. So back to the house. We are going to the emergency care response section. And I've seen Dr. Chinwe around. Welcome. Hi. So at this point in time, I would like to invite Professor Darieson and Dr. Ada Njokama. Are you here? Oh, please, can you come to here and chair this session? Thank you very much for this opportunity. Thank you so much to serve. And Dr. Oladokun, thank you. So over to my big brother, Brody. You will remember House 9 in Elisha. I won't go back to history. That is History 101.
Good afternoon, students and the staff of the College of Health Sciences. I'll be standing on the existing protocol as we continue the Preceptorship Programme this afternoon. Together with me, I have my colleague here, and we're going to moderate this session, Dr. Njokama. Yeah. So we have two speakers for this session, and one of the speakers is already with us online, and I don't know whether the second speaker is around. Before we go into that, let me just welcome my teacher, Professor Adegbengbe. He worked in Y. He's my big teacher, okay? And he's the first man in the college. You understand that? Uh-huh. Okay. So we're going to talk about emergency care response this afternoon. And just to let you know that emergency care response, it's a big deal for healthcare workers. And here this afternoon, we have dentists, we have doctors, we have nurses and physiotherapists and nutritionists. And we all, we work together when we have emergencies. And it's very critical in health sector. And it's a topical issue that we need to talk about and we need to know and learn about. And as it were, today in Nigeria, we still don't have enough specialists in this area. We don't have enough specialists in this area. And it's a core, a different area of medicine that deals with handling of emergency problems. And we have a lot. We have medical emergencies, we have surgical emergencies. And I can tell you that even the trauma aspect of emergency, if you combine the death by AI with death from HIV to emergency trauma worldwide, annually, up to about 5 million people die annually from trauma, from trauma that needs emergency treatment. So you can then imagine emergency medicine, the heart attacks, the acute severe asthma, the strokes and everything. And, a lot of our patients die from this. And this afternoon, we have experts in the house they are going to do justice to this topic, stimulate our interest, to develop interest in emergency care, and, prepare us for what is ahead of us as healthcare workers. Thank you.
So our first speaker, So our first speaker, Dr. Oyedekun, is online. You're welcome, sir.
Thank you very much.
Yeah. Okay, so the citation for our first speaker is to be taken by Ojamu Isuayo. Is she here? Okay. Please come forward.
Distinguished guests, ladies and gentlemen, I'm privileged to read a brief citation of Dr. Oyedekun. My name is Ojamo Isuayo Oreoluwa. Dr. Taofik Olusegun Oyedekun, a proud alumnus of Femi Awolowo University, is a clinical associate professor at the College of Medicine, University of Saskatchewan, an emergency physician and trauma team leader with the Saskatchewan Health Authority, and a transport physician with the Shock Trauma Air Rescue Service, SPARS, in Canada. He also serves as an assistant program director for the Saskatchewan International Physicians Practice Assessment (CPAP) program, supporting the integration of international physicians into clinical practice in his province. He is actively engaged in patient-oriented research and quality improvement initiatives. Outside of medicine, he enjoys playing football and continues to represent Canada internationally with the Canadian medical football team. With
think I lost audio from Ife.
Yes, we cannot hear them for some reason.
Yeah.
I'm going to put it in the chat. I'm going to chat with them.
Hear us now.
Yes.
Can you? Yeah, no, yeah, I can hear you now. Can you hear me?
Yes, we can,
Okay.
loud and clear.
All right. Thank you very much. Good afternoon, everyone. I am deeply honored to be invited to speak at the 2026 Preceptorship Programme. I would like to thank the organizers, especially Professor Adegbengbe and the College Alumni Relation officers, as well as the moderators, Professor Esson, Dr. Joe, and the kind introduction by Ojamo Iswanyo. I just going to go ahead and share my screen. Can you see my screen?
Yes, we can.
Oh, awesome. Thank you very much. So I am indeed privileged to have trained in and worked in 3 different countries, and I'm always grateful for the solid educational foundation laid for us in Ife. I feel really blessed to be an alumnus of this great institution, and I always enjoy my trip to Ife whenever I come home. Indeed, there is no place like home. I also feel honored to share the virtual podium with esteemed colleagues, my seniors, Professor Dike, Professor Gedegbe, with whom I'll be sharing this topic, and my classmate, Dr. George Umar. One of the fondest memories is captured by this picture. This was our team picture during the Okediron Cup finals in 1985, well, against Professor Dike's team. It was one of the toughest and the best games I ever played. And I'll let you guess who won. That's me right in the middle there, very young looking. And Dr. Umar, 2 people to my right. At the end of the session, we'll get answers to the quiz. So I'd just like to share 3 cases, 3 vignettes, just for you to ponder over. We're not going to discuss any of the cases. The first one is a 20-year-old student who collapses during an intramural football match between health sciences and education on campus. What do you think will happen next? What kind of emergency medical response do you expect? The second case is a 30-year-old man with decreased level of consciousness after an unwitnessed fall at home. He is suspected to have consumed alcohol and possibly sustained traumatic brain injury. He probably had a seizure, we're not sure. So he's at home and is 2 hours away from the nearest hospital. Again, the question is, what kind of assistance is this person going to receive? It would likely be layperson first aid if the person nearby knows what to do. And the third case is a 32-year-old man involved in a motorcycle crash. He collided head-on with an SUV, is unresponsive and in shock, and is 2 hours away from the nearest general or teaching hospital. It's very likely that the initial response, initial care will be provided by fellow road users, could well be members of the Federal Road Safety Corps that would show up to provide assistance. Question is, what are these person's chances of survival, knowing that about 80% of deaths due to severe injury occur in the pre-hospital setting? So again, I don't think any of these cases is too unfamiliar to you, the question is, what kind of response what kind of assistance should these people receive, and what kind of assistance do they actually receive? So here are the objectives for this session. At the end of the few minutes we have with you, you'll be able to define emergency medical care, response systems. Next is to describe the chain of survival. It's been described by various resuscitation organizations. I'll be using the American Heart Association and the Heart and Stroke Foundation of Canada, chain of survival model, as well as the European Resuscitation Council. They're similar, slightly different, but again, same idea. And then discuss the current state of emergency response in Nigeria, and move on to identify major gaps in Nigerian out-of-hospital emergency care. And I'll be speaking about this concept of out-of-hospital emergency care, pre-hospital care, emergency medical services. Some of these terminologies are being used interchangeably, but there's a kind of shift towards out-of-hospital emergency care, and I will explain why. And lastly, to explore realistic, evidence-based improvement strategies. So emergency medical care response is a huge topic, and there's no way both of us can do justice to it in 2 30-minute talks. We're only going to scratch the surface by sharing some concepts and thoughts. And we will do our best to fill in some gaps during Q&A. Obviously, there will be some overlap between what I'll be sharing with you and what Professor Ogedegbe will be sharing. But the bottom line is to challenge your thinking and stimulate your interest during this lecture and moving forward. And as Professor Dari said, emergency medicine is a relatively new specialty in Nigeria, and the secret agenda I have, and I am sure Professor Chinwe will share the same sentiment, will be to stimulate your interest in emergency medicine as students that are present here. So thank you for availing yourself. Thank you for joining us today. And before moving on, I would also like to acknowledge some of our colleagues, classmates that are here to support us. Professor Razak Adebayo wasn't in that picture. I don't think he played much soccer, but Drs. Adebanjo and Desalu are here in the audience. And thank you for joining us. And thank you everyone for making yourself available today. So emergencies are time-sensitive conditions, and sometimes minutes determine outcomes. As depicted in on this slide, time is muscle, as in cases of acute coronary syndromes or acute myocardial infarction, as well as in stroke, and hence the saying, time is brain. Other conditions like trauma, sepsis, and obstetric emergencies also require timely and rapid response. So emergency medical care matters because many deaths and disabilities are preventable with timely care. So what is emergency medical care response? So it is the coordinated delivery of medical care from the scene to definitive care. And I would like you to note the words or the phrase in bold here. It has to be coordinated for it to work. And it starts from the site of injury or home or the scene, and all the way to where definitive care is provided. It may well be the patient ending up in the operating room or the ICU or admitted to the unit, or maybe the person is well enough to be discharged from the emergency department. So it includes public recognition, dispatch, emergency medical services, hospitals, and rehabilitation. And I'm glad to know that we don't only have medical students here, we also have nursing students, perhaps we have rehabilitation students. So it's emergency care is very much multidisciplinary. And yes, it does require teamwork and a well-integrated system. So let's talk about the chain of survival, the concept of chain of survival. Survival and recovery of patients or victims from cardiac arrest depend on a complex system working together to secure the best outcome for the victim or patient. And this system is depicted by the chain with 5 links. And weakness or break at any link will result in a poor outcome. So it is a continuum, and every part of it must fit. It involves early recognition and activation, early CPR that is of high quality, early defibrillation, advanced resuscitation as part of advanced life support, and post-cardiac arrest care and recovery. So the one on top is the chain of survival from the American Heart Association and the Heart and Stroke Foundation of Canada. And the one below is from the European Resuscitation Council. Again, they look different, but they're exactly the same thing. Myself and a few colleagues within Nigeria and outside of Nigeria did a narrative review and published it in the African Journal of Emergency Medicine a few years ago, precisely 2023. And what really led to this was my personal interest and personal observation. I come to Nigeria fairly frequently, at least once in a year or two, and I couldn't but notice the gaps in the peri-hospital setting. And I'm sure you all know that perhaps until recently, out of hospital emergency care or emergency medical services were largely provided by the Federal Road Safety Corps, the National Emergency Management Agency, some states, state emergency medical service systems, and private and hospital-based ambulance services. So I'll be sharing some of our findings from that we published in this narrative review, and again, many of the things we found are not strange to you, things that you're already familiar with, things you experience day by day. And I must also mention that in no way are we experts in what's happening in Nigeria, but the idea is to just kind of stimulate your thought and stimulate interest, and hopefully we can learn from your experiences as well. Why use these different concepts? What's the difference? What are the similarities? Pre-hospital care, out of hospital emergency care, emergency medical services. In 2011, the African Federation on Emergency Medicine proposed the prioritization of development of pre-hospital emergency care systems by African stakeholders, and it's done through a consensus process involving several experts. They meet every 2 years during the African Conference on Emergency Medicine, and one of the priorities was to define the various terminologies so everyone could be on the same page. So, and hopefully this slide will kind of clear things up. This slide depicts the continuum of comprehensive emergency care as proposed by the African Foundation on Emergency Medicine, and it starts with emergency care system activation. As you notice, this almost looks like, or it has similarities to the chain of survival concept. So the emergency care activation system involves toll-free public access number, and then move on to tier one response. The tier one and tier two responses were described by the World Health Organization. And tier one response is basically the response that involves community members, police, and fire, and so on. While tier two response involves trained professionals, and then the next step in the continuum is emergency transportation, which is typically provided by EMS or paramedics or other specialized services. And then it moves on to the in-hospital part, which is basic in-hospital emergency care, and of course, going to a higher level with advanced and definitive emergency care. So basically, why this is important is, for the most part, when people think about emergency medical services, you're thinking about paramedics coming with an ambulance to take the patient to the hospital. But the idea behind this is we need to place a huge emphasis on the actual emergency care system activation, what people should do immediately, and what community resources can be utilized as part of the tier one response and care to provide immediate assistance for the victim or for the patient. So basically, pre-hospital care was agreed upon to refer to out-of-hospital emergency medical care delivered by a professional provider with the ability to provide transport to a healthcare facility. And the out-of-hospital emergency care should involve every aspect of what happens outside the hospital. I hope that makes sense. Again, just to reiterate, the role of the public, the role of the layperson, the role of the bystander is very important, and that's an area we also need to focus on when developing emergency care systems in Nigeria. So, Emergency Response Africa is an organization that operates a network of trained first responders, ambulances, and verified emergency-ready hospitals in Nigeria. And they did a survey a few years ago, 2019 precisely. And the main finding, which is quite astonishing, is the fact that only 30% of people call an emergency number or ambulance service as the first step to get help during an emergency. And as shown on this slide, approximately 18% will call a doctor or nurse, 36% will call someone nearby, a family friend or bystander, and 42% will drive, borrow, or hire a vehicle to get to the hospital. So this is very, very important. Yeah, for early recognition and activation, especially out of hospital, public awareness is essential. We need a reliable emergency access number, and delayed activations contribute, as we know, delayed activation contributes to poor outcomes. Unfortunately, poor public education still remains limited. So, and I would like to hear from you folks what the situation is. We do know that the lack of a universal number for emergency services has been identified as a significant cause of delay in receiving emergency care. In my neck of the woods, if you call for an emergency based on the information you give the operator, typically we use 911. you may be transferred to the police, the fire services, and the ambulance. And you will be encouraged to stay on the line until the right connection is made. Sometimes all three services will respond or will be dispatched. So I guess my question to you is, how many emergency numbers do we have? I have seen quite a few. Will there come a time when we have a consistent number, reliable number? I look forward to hearing from the audience as well. So the next step after emergency activation is providing immediate CPR in the case of cardiac arrest. There's good evidence that immediate CPR improves survival. But unfortunately, we do have low bystander CPR rates in Nigeria, and for many reasons. The barriers include lack of training and sometimes fear of legal consequences. So we need to have well-established community CPR training programs. And next is rapid defibrillation. Defibrillation within minutes saves lives. But that depends on the availability of a defibrillator, even AED. We know that there's availability of AED is limited in Nigeria. Public access defibrillation programs are practically non-existent as far as I know. Ideally, AEDs should be placed in public venues, in airports, schools. So the question is, how many defibrillators do we have, and where are they placed? How many do we have on our university campus in Ife? How many do we have in the hospital? Next level is advanced support, which is it includes airway management, medications, monitoring. This requires trained personnel and equipment. And it really shouldn't be limited to physicians or experts. It shouldn't be limited to anesthesiologists, emergency physicians. In fact, nurses, medical students, other emergency care professionals should receive and be able to provide advanced life support. So training gaps remain a major challenge. And then next is post-cardiac arrest care, which often requires ICU and multidisciplinary support. We do know that resource limitations do affect outcomes, and we do need stronger critical care systems. So how many ICUs do we have? How many beds do we have in our ICUs? How much resource do we have in these places to provide the much needed care? So in this paper, which I'm not ashamed to promote it. It's a really good and simple read. It was definitely quite, doing this work was definitely eye-opening for me and my colleagues. And some of the key barriers we identified are cultural and community barriers, training and workforce gaps, infrastructure limitations, weak policy, and poor funding support. And again, I'm sure none of this is news to you. These are common, but what we endeavored to do was actually look at peer-reviewed papers and just scope those peer-reviewed papers and put together these barriers and propose some solutions. Now, we're in an academic environment. This session is very academic. So question is, what is the role of universities and teaching hospitals in emergency medical care? First is, which I would like to really encourage, is our higher institutions should lead EMS research and training. I am very excited to be part of the emergency postgraduate training in emergency medicine in Nigeria, and I know the training has started in Ife as well. I'm really excited about that. I'm hoping it will grow, and I'm hoping it will get the required support for its expansion. And we need to develop and maintain simulation centers. Emergency care, resuscitation care requires lots of practice, lots of training, and we need to be able to support first responder education as well. Again, it's not only training shouldn't only be for critical care physicians. We need to be actively involved in supporting first responder education as well, so they can be part of the chain of survival, especially the early part of the chain of survival. And we should be able to influence policy and advocacy. What we do should be data driven. So with research, training, availability of data, we should be able to use that to influence policy and advocate for improved care. What about you as students and residents present here? Again, resuscitation training, emergency pre-hospital training, emergency care training shouldn't be limited to experts. You as students could learn and be able to teach CPR to peers and to the public. You should participate in advocacy as well. It shouldn't be left for the professors and the highly placed people. It should be something everybody should be part of. You should show interest in conducting emergency care research, and you should be part of promoting innovation and leadership. So,
Please, sir,
yes?
Just a time check, sir. 5 minutes.
Okay. Yes, I am about 2 minutes out. I'm almost done. So thank you. So some of the innovations or advances in emergency care, an innovation by the Health and Stroke Foundation of Canada is a cardiac crash monitor, which is a gamified approach to teach CPR and AED skills in schools and workplaces. We introduced this CPR training in end of March when I was home, and I do believe it was very well received. It's a very cool way of teaching CPR. And organizations like Health Ethics and Law Consulting are very much interested in improving access, emergency care access in Nigeria. And last year, they brought together quite a number of experts to discuss ways of improving access. And recently, the Health Foundation of Nigeria, Healthcare Foundation of Nigeria, and Health Emergency Initiative signed a memorandum of understanding to establish the Medical Intervention Trust Fund, which is to help improve emergency response and financing, be a part of training, support indigent patients, and equip hospitals for readiness. So I would also like to quickly mention the expanded role of paramedics, especially where I am. What they do is beyond just driving ambulance or providing care outside the hospitals. They also can actually help in the community, help with in providing services in the community by way of visiting, doing home visits, and traveling on buses to provide care to the public. And I would like to share, in closing, just share a success story. about how the public must be involved in emergency care. These two boys, this happened in my community here in Saskatoon in Canada. A 10-year-old boy and his brother started CPR on their grandmother, a 62-year-old nurse, after she had a cardiac arrest at home. So Ken, the older boy, was able to call 911 and stayed on with the emergency dispatcher who told him what to do. So the 62-year-old grandmother was successfully resuscitated due to efforts of her grandsons as well as paramedics who defibrillated her 4 times, got her back, got her to the hospital, and she's back to work. So in conclusion, emergency care systems save lives. Nigeria faces challenges, but there are also lots of opportunities for improvement and development. Evidence-based practices must adapt to local realities, and Nigeria is a good example. We can't expect Nigeria to do exactly what England or the US or Canada does. We have to adapt to local realities. And lastly, leadership, training, and collaboration are essential. Big shout out to any paramedics that are present here. It's EMS Week, so happy EMS Week. Thank you very much for the opportunity to share some thoughts with you.
Thank you so much, Dr. Oyedokun, for that lecture. I know the time allocated was quite short because this is actually a very burning topic for us in this part of the world because we have many challenges with emergency medical care response. And the way you categorize this emergency care response, I know typically we think of that, we think of the doctors. What are the doctors doing? What are they doing in the hospitals? But you highlighted the role, the community, the first responders, who are the bystanders, the role they have to play in this. And I think it is very important. That's one area that I'm not sure how much we have, educated and stimulated the public. So that's a very interesting line of discussion. So we'll take questions after the second lecture. So I would like to call on Dr. Chinwe Ogedegbe to prepare to put up her slides. While we're waiting for that, her citation will be read by Mirabel Oyatogun. Mirabel, could you please come forward? Please give her a round of applause. Comes forward. Dr. Chinwe Ogedegbe will have 30 minutes for her lecture also. Thank you.
Good day, distinguished guests, respected lecturers, colleagues, and fellow students. My name is Mirabel Oyatogun, and it's my honor and pleasure to present the citation of our distinguished guest speaker, Dr. Chinwe Ogedegbe. Dr. Chinwe Ogedegbe is an accomplished physician scientist, professor of emergency medicine, and a leading voice in clinical trials, health equity, and medical education. She earned a Doctor of Medicine degree in 1988 from Obafemi Awolowo University, Ife, Nigeria, followed by an emergency medicine residency at Mount Sinai Hospital, New York, and a Master of Public Health from Columbia University, New York. She recently expanded her leadership and business acumen by completing an MBA. With over 25 years in emergency medicine and more than 15 years of experience as a research scientist, Dr. Ogedegbe has led high-impact clinical trials and public health studies. She has served on institutional review boards and partnered with major funders, including the U.S. Department of Defense, the Centers for Disease Control and Prevention, the National Institutes of Health, the Patient-Centered Outcomes Research Institute, the New Jersey Department of Health, as well as the pharma industry. A prolific academic leader, Dr. Ogedegbe served as the inaugural Vice Chair for Academic Affairs in Emergency Medicine at Hackensack Meridian School of Medicine. She designed and led the emergency medicine residency research curriculum for a decade, bridging undergraduate medical education, graduate medical education, and faculty development. She has mentored over 130 emerging health professionals and has authored more than 105 publications in peer-reviewed journals. Her work focuses on evidence-based interventions to improve outcomes among diverse emergency department populations. Signature research initiatives include smoking cessation, alcohol use disorder, palliative care, HIV and viral hepatitis stigma reduction programs, as well as clinical trials involving stroke, seizures, and diabetes. More recently, she has led grant-funded programs targeting hospital readmissions, emergency department recidivism, and health equity through screening for social determinants of health. Dr. Ogedegbe was also an associate member of the Center for Discovery and Innovation and the Joanthera Cancer Center in New Jersey. She was the recipient of a cancer education and early detection grant supported by both state and federal funding. In August 2023, Dr. Ogedegbe and her team achieved national distinction by earning the first ever advanced certification in healthcare equity awarded by the Joint Commission in the United States. As health equity lead at Arkansas University Medical Center, she drove system-level strategies that positioned the institution as a leader in equitable healthcare delivery. Internationally, Dr. Ogedegbe recently launched Intelligent Clinical Trial Solutions Nigeria Limited, a physician-led clinical research organization committed to advancing investigator-led clinical research networks and improving diversity in clinical trials across Nigeria, Africa, and beyond. Distinguished ladies and gentlemen, please, with a round of applause, join me in warmly welcoming Dr. Chinwe Ogedegbe. Thank you.
Thank you so much. Thank you. Please, by thumbs up, could you let me know if you could hear me, please? Okay, thank you.
We can hear you, ma.
Awesome. So I'm going to go very quick. And I also want to mention a shout out to Professor Bernice Adegbengbe, your wonderful provost, who called me last minute and said, come join, come join today's presentation. And I went along with the theme, though at the end, the theme is mental health and wellness and burnout, right? In emergency medicine. I decided to bring that out in emergency medicine. But at the end, since there's such a wonderful audience of young minds, I would like to mention a few key things for emergency medicine to spark your interest in that and to actually make sure we know that it's super important, just like Dr. Oyedokun had mentioned. So I want us to begin by remembering this wonderful quote by a very famous poet in the US, Maya Angelou. She says, as you grow older, you will discover that you have two hands, one for helping yourself and the other for helping others. It's kind of going with the theme of what the last two speakers, actually speakers before Professor Oyedokun mentioned about be kind to yourself. So very quickly, the objectives are going to be to mention that burnout also happens in emergency medicine. In fact, we are the highest of all physicians, the highest rate of burnout is actually in emergency medicine according to literature. So recognize the signs of burnout, moral injury, compassion fatigue. You heard some of these terms in the previous first two lectures from today. Review evidence-based data on physician mental health, discuss operational and personal interventions, and explore leadership strategies for sustainable emergency room or emergency department wellness culture, and consider brief vignettes. Why does this matter? Why should we care? Hospital jobs compared to outpatient jobs have higher burnout rates. So for example, emergency department docs, myself and Dr. Oyedokun, experience amongst the highest burnout rates. The lowest are for those physicians who do lots of outpatient care, infectious disease doctors, primary care doctors, not people who are in the hospital. This is what the literature says. ER's team face chronic exposure to trauma, overcrowding, violence, and sleep disruption. So burnout impacts us very significantly in areas like patient safety through medical errors. You're trying to take care of a patient, and because you're a little tired, you put the wrong dose in. That's a huge medical error. And because we deal with such critical moments, it's almost always life and death. So it's almost a catch-22. We have to be very, very cognizant of that as ER docs and as physicians in general. So it also affects talent retention and workforce sustainability. I want us to consider the literature. I went all the way from 2004 through 2019 and 2025. This 2004 article by Shenhammer really talks about suicide, right? It just focuses a lot on the physicians and suicide, and it actually tells us that females actually attempt much more suicide and males complete it more. Then the article of 2019, this one here by what's his name? Dean, Wendy Dean. 2019 article focused a lot on moral injury and not burnout. Just saying that the reframing of the clinical question of the syndrome, clinician distress, is actually more of moral injury versus burnout. So try to distinguish the two. That was in the MDEG network article. And the third one I'd like us to consider is this paper on JSEP. This is a new emergency medicine journal, JSEP. This 2025 article by Jackman et al. Talks about the MASLAC burnout inventory. So anytime you have any condition, it's very good to use a measure or an inventory to get specific elements of it to be able to quantify it. So that's very much explained in this article. And then lastly, we have the JAMA Network Open article by Moore and Sharif, where they talk about the burnout trends during COVID and how after COVID, the burnout trends are reducing, but still not very low as to pre-pandemic times. While talking about the scientific literature, I also wanted to mention the very, straight out of the press, hot from the press, as they say, that came out in April of 2026. A gentleman called Dr. Bobby Mukamala. He's the president of AMA in the US right now. And this article really, or this, big press announcement was that doctors spend more than half of their workdays documenting patient visits and electronic health records. So there's a new burnout phenomenon called click fatigue, because you're clicking, trying to take care of all the patients, clicking all those boxes for your EMR, which is electronic medical records. So some studies suggest using AI scribes, which automatically record these things to, again, help physicians' life be better and reduce burnout. This release was in April of 2026, and that same document showed that burnout prevalence amongst physicians is 41.9% compared to a lot of other professions. And for emergency physicians, it's actually 50%. This is all stuff that we must pay attention to. So the key statistics, again, physician suicide rates are roughly 20 to 40 per 100,000 compared to 14.5 per 100,000 for the general population. And for males, it's 40% in male physicians than men in other professions. And for women, as Professor Dike had mentioned, 25 to 130%, which is new, much steeper, higher rate in women compared to women in the general population. The terminologies mentioned earlier in the morning, I just want us to go over them so all of us know. Those some of our slides, we're going to make sure we send the slides through your provost. Some people are asking in the chat. We're happy to share them. So burnout is a work-related syndrome caused by chronic unmanaged stress, characterized by emotional exhaustion, depersonalization, cynicism, and reduced professional effectiveness. This is the WHO ICD-11 definition. Depression, as you, many of these things you guys know already, but I'm packaging it in ways that you can remember. So depression is pervasive in a simple way, pervasive mood disorder affecting all domains. Moral distress actually leads to moral injury. So moral distress is repeated exposure to systems that make good care difficult, system constraints, overcrowding. You feel bad as a physician because you went into this to really take care of people. So you're suffering from that moral distress. And then if you have a lot of that over time, you now have moral injury. That's where moral injury came from. The moral injury is a profound psychological distress that occurs when an individual fails to prevent acts that deeply violate their own moral code or ethical beliefs. Then you have compassion fatigue. What is that? Cumulative emotional burden. That's why, as Professor Dika said, and the first Dr. Umo had mentioned, find a way to release the pressure. Unpack. That's why people go on vacation, spend some time, don't think about work, don't think about, all the duties you have to do at home. Unpack so that you don't have the pressure pot syndrome. Depersonalization, what is that? Self-observation, emotional numbness. You're no more feeling, moved by anything. Terrible things don't move you. Very great things don't move you. You'll be getting a lot of, you're getting dejaded, as they say in the US. Then there's a syndrome I want to mention to you called second victim syndrome. Specifically describes emotional distress of a healthcare worker after experiencing being involved in an adverse present event or medical error. We had a resident who went through it, and it was so bad that he had to be away for 2 or 3 months. You know why? When he placed a Swan-Ganz catheter, he forgot to take out the wire, and the patient had a poor outcome, so he was beating himself down. He felt so bad. That's the second victim syndrome. You have the first victim, which is the patient, and the second victim was the care provider who made an honest medical error, but it was so bad that he felt so bad, and he had to be getting some therapy after that. So what are the specific stressors in the ER, in the emergency room, or the casualty room, as they say in Nigeria? Boarding crisis, overcrowding, violence, aggression towards staff, death notifications, traumatic cases, documentation burden, shift work, and your circadian rhythm is disrupted. This is a real case. We didn't put numbers or names, but it's a real case of a physician we had in our ER. 45-year-old ER physician, after consecutive nights, became very irritable. He took extra shifts, and it was all night shifts. He had emotional numbness, charting fatigue, tired of writing new charts. And then he had a near miss medication error after a very prolonged shift. And it had to go through a lot of root cause analysis. What happened? Why did this patient suffer? This patient didn't die, but they got the wrong dose of a medication, which he shouldn't have. He knows better, right? So this was really due to burnout, fatigue, and system pressures. Second case, we had a pediatric trauma case where a lot of people were involved in resuscitating this 9-year-old child who came on a major trauma to the trauma bay. The ER was very overcrowded. So after this physician took care of this trauma case, and then a crowded ER, he was very, stressed out, and he had no place to decompress. The room was filled up. He couldn't go somewhere and chill. And because there's a lot of patients keep coming in for help, and you're one of two doctors on in the night. So with these persistent intrusive memories and emotional exhaustion, because this physician really had a child that was the same age, right? And the appearance and disposition, he kept thinking of his kid. That could be my kid. That could be my kid. That was bothering him all night. So this is secondary trauma and leads to also moral injury. So the warning signs of this, when you have a colleague they're working with and they become very cynical, there's detachment, there's loss of empathy, and no longer as caring as they are, deemed to be in the past. They become jaded, as they say here in the US. There's chronic fatigue, insomnia, they're not sleeping well, increased conflict with their staff or family. They get irritable even at home. Some of them turn to substance use, alcohol, as ETOH, marijuana, opioids, and much more. And there's reduced clinical satisfaction. What is the impact? Oftentimes, it's impact on patient care. Increased medical error, like I mentioned, reduced patient satisfaction. Here in the US, they do patient satisfaction, send surveys out to the patients, and they score you. And you see that patients give you poor scores if you're not very, cordial with them. If you're not you don't explain to them, things like that. And then this also leads to high turnover and staffing instability. Also reduced workforce sustainability. So these are very important questions to consider with your teams. Now I'm speaking to the faculty and the leaders as well. The young students, you guys will become leaders one day. When you get to that stage, you always think and ask, is there any team member experiencing symptoms of burnout? It's like being a brother's keeper, as Professor DK said, right? Do you feel psychologically safe discussing mental health at work? This is a question for the faculty. They too should feel psychologically safe. They too should be checked and looked at because it's not easy for them. Some of them are mothers as well as professors, as well as wives, as well as community leaders in the church. So look after your neighbor, your next person, okay, including the faculty. What is the greatest contributor to your stress in the ER? Think about it for your teams. What wellness intervention would have the biggest impact? What changes can your departments implement within the next 90 days? Give yourselves a challenge as leaders. What can we do within the next 90 days to make sure our teams are comfortable? And again, it's not just physicians. always physicians, nurses, medical, associated, the other medical experts, like the medical technician that does EKGs, the nurse assistants, all the different levels, paramedics, all of them. I'm trying to hurry. Then how can leadership better support frontline clinicians? Always bring that question back to yourselves as leaders. And what barriers what barriers prevent help seeking in your institution? Here are some solutions I'm going to proffer. Operational solutions. So as leadership of the hospital, the CMD, I spoke to him some months ago, CMDs of the hospital, please think about these. Protected breaks and hydration for your crews, for your team, right? Post-trauma debriefing culture. If something comes, if a big bus comes with a lot of people, maybe dismembered, there's a lot of major trauma, have a small post-trauma debriefing culture where you all get into a room and talk about everything, and then you all take a breather and go back. Think about this and do this more often. Improve staffing models and system redesign is very important at that leadership level. Documentation optimization. Consider AI tools that could help. Violence prevention and security support for your staff. And then for personal wellness strategies, sleep recovery after shifts, peer support, peer mentorship, and resilience training. Dr. George mentioned exercise and nutrition, very important. Therapy, coaching when needed, mindfulness, and recovery rituals. So with leadership and the culture of the place, you have to normalize help seeking, meaning allow people and encourage people to seek help. I'm not feeling so good. I'm a bit down. I'm not feeling it. Normalize help seeking. Don't criticize people who offer that, I'm feeling stressed out. I'm a little down, encourage that culture. When I grew up in Nigeria, when I was, in Ife, it wasn't a thing to ask for help. Like Professor Dike said, it's almost a sign of weakness, or you're asking for help. Well, today, luckily, you millennials and, alpha generation, you guys talk about this very freely. So keep doing that, because that's the real way to go. And that's the way where you don't have more cases of suicide, all right? Recognize moral injury as systemic. It's happening a lot. 40% of people in the world have some kind of mental condition, right? Some mental condition. So it is systemic, it's everywhere. But some people are able to contain it or hide it until they can hide it no more and bad things happen. Support residents and junior clinicians, encourage regular debriefing. You say, let's talk about it. Let's have a session. In fact, little story here. I have a 24-year-old about 4 years ago, when he was in charter school here in the US. It was one of those very high pressure, high achievement, high yielding school. So there's a lot of pressure on the kids. These are kids who are top of the top, getting their grades when they get in, SATs. When they get into the school, there's so much competition with themselves. They compete with themselves. And then many of them become so sad that they want to kill themselves. And in the past, there's been suicide even in that age group. So what do they do in my son's school? Every Friday, they go in and they do check-ins. They do care check-ins. They have each of them come to the council and say, how are you doing? How is this? How is that? Is everything okay with you? So my son used to make fun, and he'll come home and I'll say, how was school? He'll make fun and say, Mom, I was very sad today. I think I'm going to kill myself. I'm like, are you kidding me? So he would use that example that this is what they do for them in school. He was actually just kidding. But it's good to have check-ins. That's a good example. Encourage regular debriefing. This topic is critical for employee efficiency, health, and happiness. So the goal is simply not, surviving emergency medicine, but sustaining the humanity that brought us into it in the first place. Again, I love looking at Maya Angelou's readings. She says, my mission in life is not merely to survive, but to thrive, and do so with some passion, some compassion, some humor, and some style. And then this last sentence she says is, I've learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. Maya Angelou. So let's be kind to each other. Before we wrap up, I wanted to just put some 3 or 4 points about emergency medicine, because that's near and dear to my heart still. Even though last summer I set up the company ICTS and I actually left my academic institution. Of course, students and my peers are still, reaching out to me, writing papers, teaching them on the side. But now that I'm trying to set up this company to improve clinical trials in the world, starting with Black communities, Nigeria, and in the US. I'm less, engaged in academic things, but still able to work as an emergency physician, still licensed, but trying to do so much more for Nigeria. And that's really why I started the company. There's so much to be done. Starting with, as Dr. Oyedepo said, AEDs, installing and training in all public places, airports, stadiums where people collapse after soccer or during soccer, right? So we need to do that. Think about reasons why you have emergency response system. You think of penumbra. Again, you young learners, the internet is your playground, right? There's so much resources out there, YouTube, all over. All you need is a word. Once you have the word, look it up and you read and you teach yourself. So some words I'm going to throw out to you while we are here today is to put this at the back of your mind. Whenever you think of this, that's why emergency response systems are important. One of the words is penumbra. Please write this down. Penumbra is the area around a stroke that can widen. If the penumbra widens, you're going to have more opportunity that the patient will not recover full function, right? There's something called the MRS, Modified Ranking Scale. That MRS number will be very high and patient will not recover their full function. So think of penumbra, read about it. Reasons for emergency response system. Another one is cardiac events, not just sudden cardiac death, but things like acute myocardial infarct. If you have an acute myocardial infarct, time is muscle, like the previous speaker just mentioned. So for cardiac cath in the US, everything emergency medicine for life support is time limited. So you have 0 to 90 minutes. Again, it's all guidelines, through the guidelines and informed by evidence-based research, right? The guidelines have shown that if you have somebody with a heart attack, the best time to intervene is between 0 and 90 minutes. So once we have a phone call that medics are bringing a patient with chest pain, everybody's thinking we got to get them to the cath lab before 90 minutes. So 0 to 90 minutes, we get graded on it and everything. That's another reason for emergency resuscitation. The next one is stroke. Stroke care is time limited as well. We have 4.5 hours, up 0 to 4.5 hours, meaning when that patient had the first symptoms. Again, it's still, that culture is still trying to be pervasive in Nigeria. It's not everywhere. We need to improve on that. So the literature is saying you have up to 4.5 hours to activate a code stroke if the patient comes in. Well, it's really up to 24 hours in more resource heavy communities like in the US, Canada, Australia, all over Europe. So we want to be like that in Nigeria where time is of essence. We have to recognize, first of all, education, recognize when they have emergencies in our community, widespread, and then we find a way to make sure our 911 system, I believe in Nigeria, I think it's 311 they call it. So you guys will tell us, please. I intend to do much more, get more involved in Nigeria now that I've left my academic, assignment responsibility since last year to push up our own system and make sure everything that we need to do, at least we begin to make it on a larger scale. It exists in Nigeria, but not as much as we want. Another concept for reasons for emergency response system is sepsis, right? When you have patients with sepsis, sepsis is pervasive and the patient could die. Here we call it EGD, early goal-directed therapy. That's one of the scientific reasons that sepsis regulations changed. We have less than 4 hours to start antibiotics and fluid resuscitation. When you do those things, patients has a much higher chance of survival. So there are many things emergency medicine that actually, make a difference in saving lives. The last thing I'll say is what Dr. Hideko mentioned, CPR. How many of you have cardiopulmonary resuscitation certificates? I'm going to volunteer and probably work with your provost, Professor Adegbengbe, and even your previous provost, Professor Ijadola Kayode, my classmate, my dynamic classmate. Work with them and find a way how we can get either local sponsors, and some of us will give our free time, local sponsors to buy the equipment to do free CPR training. Myself, and I'm going to volunteer, Professor Dr. Segun Oyedeku. Let's join hands and give our students, our alma mater, right? Free CPR training. because it's easy. I do it all the time here. I even do it with AMPA. We just came back from Abia and Imo where we did CPR training for AMPA medical mission. We want to challenge ourselves in the diaspora to bring this free training. CPR, ALS, BLS, advanced cardiac life support, there's basic life support. So I think we should do that as part of our plan for emergency medicine. I would stop there. Thank you.
Thank you so much, Rob. We really enjoyed your session, and we can't but just appreciate the effort you have put into this to educate us on the necessity of emergency care and how we can log into it. And I believe a lot of our students are already stimulated. They are thinking towards specializing in emergency medicine as soon as they are done with their medical training, and so that we can take care of our ailing population. Thank you very much. Because the time is not on our side anymore, we want to quickly open up the space for questions and comments on the presentation. Questions and comments from the audience, from the students, from the faculties there. Let's make it snappy. Maybe one question for the speakers, one question for Prof, and one question for Dr. Oyedeokun. Question from the audience. Yes. Any other question from any other quarter? Okay, can you please come forward, ask a question? I have read Dr. Oyedeokun's papers on emergency care published in the African Journal of Emergency Medicine. But today I have put a face to the paper, to the name on the paper. Well done, sir.
Yes, sir. Thank you very much, sir, and more for the presentation. I'm Sunday Akinu. I'm a final year medical student, and I would like to ask some questions. Thank you very much. At the outset of the lecture, the purpose of is to stimulate us to have interest in emergency medicine. A few years back, maybe about 3 years ago, I'll be having such interest in emergency medicine. Even one of my colleagues has been considering emergency medicine as a specialization. So I want to ask if there are platforms for us to engage in for mentorship, and also if there are scholarship available for us to log into so that we can have this specialization done. Do you have any scholarship opportunity for us as students? Thank you very much, sir.
Okay. Thank you very much, Sam. So my name is Deborah Ushanu, a 400 level occupational therapy student. And I want to share a personal story. So I was coming back from campus one particular night, and I witnessed an accident very close to my house. Like it was a motorcycle, someone that wanted to cross the road, and it was quite far anyway. And I somehow stood where I was, and I was quite confused of what to do, like the intervention to give. And when the first speaker was giving the presentation, he gave a similar case study, which I was actually out for, that would review the case study he gave. And in that case, because I actually eventually I moved towards the accident scene to just try to tell the people that were around to because they were still passing blame of you have not done this, you should have done that. And then there was also the part of the people that were around, they were like, okay, they should take the people that have taken away from their side. So police will not come and carry them. They cannot take responsibility for what's happening. So I have to go there and still tell them to calm down. And there was someone that was quite unconscious that you, in fact, the annoying part was the fact that they were they were beating me, telling me, Baba don't die, Baba don't die. So I was just in the middle of all of that, and I was okay, what should I do? And then okay, I just had to tell one of my classmates that okay, we are health professional in the making, let's go to the accident scene. So I would like to hear your perspective on what we are supposed to do in that kind of scenario. And yes, and also how to properly educate people that are around as well, in like on the response, like their response to the like the emergency and all of that. So yes, thank you.
Thank you very much. Over to you, sir.
Thank you very much for those
That's what you do.
questions. Yes, can you hear me? Yeah. So for the first person, thank you for your interest in emergency medicine. It's one of the best decisions I ever made. My original plan was to become a gynecologist. I had passed my primary fellowship examination in Nigeria before leaving, and serendipitously, I ended up in emergency medicine, and I have no regrets. It prepares you for life in general in medicine. It prepares you to handle multiple situations. So I would encourage you to continue to pursue that interest. In terms of what specifically can be done, personally, I have made it a personal. I've made a personal decision to every opportunity I have to come to Nigeria. I try and come to Ife, just be present, just to let people know that there's a specialty called emergency medicine. It's a good one, and to encourage people to provide training. My medical school just signed an MOU with University of Juba in South Sudan. We actually visited South Sudan last September, just did a site visit, and I am in the process of getting my medical school here to sign a similar MOU. My university signed a similar MOU to with IFE, to partner with IFE. One of the things we plan to do with South Sudan is have academic cooperation, have their residents and medical students join our academic rounds, collaborate in areas of research, maybe send residents and students there, maybe have their own residents and students come here, come to where we are here in Canada. I'm hoping to do the same with IFE, God willing. I would do my best. So far, what my head of department is saying is, let's finish what we started. Well, let's settle down with South Sudan, and then we'll look at Nigeria. And one of the leaders in IFE, Professor Okwala, happens to be a good friend and brother as well. Him and I have been talking about fostering that kind of relationship, and we will continue to engage in discussion. So I look forward to ongoing partnership with IFE and actually make it formal. And I'm glad to co-present with Professor Gedegbe. I'm so excited, and I am very sure together and in collaboration with other like-minded colleagues, we will support IFE as much as possible. I don't know if Professor Gedegbe want to, I don't know if the second question was addressed to me or...
I think we should both touch on each question, but just make it short. Go ahead, please.
Okay. Yeah, so for the second one, trauma, I want to salute your courage for stepping up and wanting to assist. There's something called the Good Samaritan Act, which really protects lay people trying to help in emergency.
as long as you don't do something egregious. For example, you're intoxicated, you're drunk, and you're trying to provide, medical care, and you do something terribly wrong, that would not be acceptable, but just do your best. And what I would encourage you also to do is use that as an opportunity to develop, I guess, a professional learning plan. You've identified that you're probably not as equipped as you would like to in providing support. Go and learn. Whatever, like BLS, as Professor Godebe said, get your BLS training, get your advanced life support training. If you have an opportunity to do the trauma life support course, do whatever opportunities you have to improve yourself, do. Yeah, thank you very much.
Great. So thank you. I agree with both your points. I'm just going to add that in terms of training, for those of you who want to do emergency medicine, there's also a friend of mine called Dr. Otunde Ashaolu. He's in the postgraduate college for emergency medicine. I think there are 2 or 3 inducted people so far. He's in Abuja. I'll get his information and pass it on to your provost, Professor Kemi Bernice Degbengwe. I'll pass that information to her so she can.
Professor Odedebe, I'm sorry to be jumping now. I'm happy to see you. I've been distracted because we have some visitors in the university we have third fund officers coming from Abuja, and they are looking at some of our projects. So I had to leave that all, but I've been on the Zoom because I cannot afford to miss your presentation. So I want to say a very big thank you for you to attempt to present this preceptorship, despite the very short time like that you have, because when we are in a corner, I had to look at people that I think can bail me out, and you really bailed us out. Thank you so much, my darling sister, my classmates. I thank God for all you have achieved over there in the US, and I believe that by the grace of God, your alma mater, OAU, College of Health Sciences, we are going to benefit more and more from you. Thank you so much. And I want to use the same opportunity to thank Dr. Shadike, another classmate of mine. I'm so proud of you people. You have really made our college proud today and ever. You have always been, we have been following you up, and you have been a pride of our own college and university. So, Dr. Yedokun, I want to sincerely appreciate you, and Dr. Umar, you are wonderful. We have enjoyed your presentations today, and I can't say anything than to say thank you. I'm so sorry I was not able to be in the hall again after the initial introduction, because we have some visitors from Abuja, as I said, and we have to arrange meeting them and then sort out some officialities. So I want to say once again, thank you all. God bless you, my dears. Thank you.
Thank you so much.
Thank you. Thank you.
Thank you. So, Professor Dr. Yedekun, please, I love everything you're doing. Since I'm not going to be as busy academically in the US, meaning they're still reaching out to me, but I don't have any, I don't have a boss saying, come and teach, come and do this. So I'm able to be a bit flexible. And I think we should join hands together and do some kind of CPR course annual in Nigeria, in Ife. So if we are able to, when we did this course, I did it in Uyo, I've done it in Lagos with different groups that have asked us to come and teach. One of the young doctors in Lasug used the certificate she got, and when she went to the UK, with that little certificate, little card that she got for BLS, she got a job and she gave testimony. So those little cards are very important, and they're recognized because they come from recognizable institutions abroad. So we'll work together with Professor Bernice and try and bring some more of these things. I also want to shout out to a lot of our colleagues who gave some funding for the anatomage. That's a big, live, simulatively live mannequin to help young medical students learn. So that's all I'll say. Thank you for having us, and nice meeting you, Shego. Thank you.
Thank you very much.
Thank you.
Yes, sir. Dr. Idokun, thank you. God bless you. Nice to see you here. God bless
Thanks,
you. I
Prof.
appreciate it.
God bless you too. Thank you.
Give
Thank you
the
so much.
speakers a round of applause again. Thank you so much, Dr. Imo. Thank you so much, Dr. DK Charles. Thank you so much, my Professor Gedegbe. Thank you so much, Dr. Yodoku. We appreciate you, sir, and ma. Thank you so much. All right, so we're moving forward in the program. Almost done. I trust we've been having a great time so far. All right, so we're moving forward to presentation of awards, and I'll be okay. So I'll be calling on for our first speakers, for our first presenters that presented on mental health among healthcare professionals, identifying challenges and charting the way forward. I would like to plead the indulgence and to call Professor Shola to present these awards. I think we can do better without. Thank you so much, ma. Please. Also, can Jola in your please check to receive the award on behalf of Dr. George. Can Ojano Israel please step forward instead? Thank you. So this award is to be presented to you on behalf. Okay.
Good afternoon, faculty. Good afternoon, future health professionals. I'm sure you will agree with me that we have had a very wonderful time. Personally, I have learned a lot. And this first award is to appreciate Dr. George Umo on his presentation on identifying the mental health challenges to health professionals and charting a way forward. We recognize your valuable contribution as a guest speaker at the 2026 Preceptorship Programme of the College of Health Sciences, Obafemi Awolowo University, today, 20th of May, year 2026. So I'm presenting this award to you. They're receiving it on behalf of Dr. George Humor. So please give a very big round of applause to Dr. George Humor for his very, very stimulating talk. Show them. Thank you, Dr. Umar. Thank you. And the second award is to Professor Charles Dickey, also for his very stimulating talk on mental health challenges among healthcare workers. This award is presented by the College of Health Sciences, Obafemi Awolowo University. And to appreciate your valuable contribution as guest speaker at the 2026 Preceptorship Programme, held on 20th of May, year 2026. So please receive the award on behalf of Professor Dike. I personally want to thank both of you for the talk and for making time to remain with us at the program up until now. Thank you very much.
Thank you so much, ma. All right, so we're going to be presenting the awards to our next presenters, our next group of presenters, and I would like to call on a very distinguished personality in our midst, in person of Professor Adegben to come and present this award. We can do better with our. Thank you so much, sir. Please can Tosin Solomon from Medicine please step forward to receive this Shego.
Thank you so much. Want to say thank you on behalf of the College of Health Sciences for the stimulating lecture and insights to the current challenges for healthcare in sub-Saharan deserts, where most of our facilities are yet to meet the international standard, not to talk of the addition of a Japa syndrome, the impact of it. Today, we've been enlightening and want to say thank you to Dr. Oyedokun. On behalf of the College of Health Sciences, Obafemi Awolowo University, Ile-Ife, this award of appreciation is presented to Dr. Shego Oyedokun in recognition of your valuable contribution as guest speaker at the 2026 Preceptorship Programme held today on 28th May 2026. We want to say thank you.
All right, for the next award presentation, the award is presented to Dr. Chiwe Ogedembe. For this and to represent our year physically, can we please step forward? Thank you.
Thank you so much. I want to say thank you, Professor Chiwe Ogedembe, being with us, enlightening us, and giving us hope when things seems to be difficult. You're giving us hope of action, of knowledge and skill. Subsequently, bring us out. Battlefront is moving from analog to digital media, and emergency is essential for survival of the next generation. Having said that, on behalf of the College of Health Sciences, Obafemi Awolowo University, Ile-Ife, this award of appreciation is presented to Professor Chiwe Ogedembe in recognition of your valuable contribution as guest speaker at 2026 Preceptorship on 20th May 2026.
Thank you.
All right, thank you so much, sir. We're coming to the end of the program, but before we move forward, before we proceed, once again, I would like each and every one of us to give a resounding applause to our guests. In fact, I really think they deserve a standing ovation at this point. They have come into us because can everybody appreciate these wonderful people? Thank you so much, Saz and Mom, for coming to us today. We do not take it for granted and we truly say thank you. Please have your seats. Thank you so much. So moving close to the end of the program, I would like to say this. My name is Mutura. It's been a great privilege to be your anchor for today's program. Thank you so much for being an amazing audience and from staying till from beginning to the end. Right now, indulge me with a gift Students Association in person of Ajibade Anna to take the vote of thanks. We can do better with our applause. Thank you.
Thank you so much, Moturayo. Good evening, everyone. Distinguished college leaders, professors, lecturers, speakers, moderators, and my fellow students present here today. My name is Anna Ajibade, and I'm privileged to be the president of the Obafemi Awolowo University Dental Student Association. And I'm also honored to stand before you today to deliver the vote of thanks on behalf of all students of the College of Health Sciences at the Preceptorship Programme, which precedes the 18th Professor Grillo Distinguished Alumni Lecture. Today's event has been a beautiful blend of learning, engagement, and inspiration, and we are sincerely grateful to everyone who contributed to making it a remarkable experience for us all. First and foremost, I would like to specially appreciate our highly revered provost of the College of Health Sciences, Professor Bernice Adebengbe, for her exceptional leadership, motherly care, and unwavering commitment to the welfare and growth of students within the college. Thank you so much, Ma, for always prioritizing excellence, creating opportunities for growth, and ensuring that students of this college continue to thrive academically and personally. We sincerely appreciate you, Ma. Please, can we kindly give our provost a resounding round of applause? Thank you so much. I would also like to appreciate the esteemed moderators for the first session, Professor Akin Sulore and Dr. Oladoku in absentia, for expertly anchoring the session on mental health among healthcare professionals and adding so much depth and perspective to the conversations we had today. Our immense appreciation goes to Professor Charles D.K. and Dr. George Umo, our speakers, for their insightful lectures and timely conversations on mental health. Coincidentally, May is globally recognized as Mental Health Awareness Month, making this conversation and event even more timely and important, especially within the demanding environment of medical school and healthcare practice. Thank you for reminding us to give ourselves grace, to prioritize our well-being, and understand that caring for others also requires learning to care for ourselves. For the second session on emergency care responses, I want to specially appreciate the moderators, Dr. Ojo and Professor Dara Eson, for expertly steering the session and enriching the discussions with their valuable contribution and experiences. I also want to sincerely appreciate the speakers, Dr. Chinye and Dr. Shegun Oyedoku, sharing practical knowledge and insights on emergency care response. Thank you for equipping us with lessons that will remain relevant throughout our professional journey. Heartfelt appreciation also goes to our Master of Ceremony, Apampa Moturayo, for coordinating and moderating this entire program, backed by such short notice, with such eloquence, elegance, and excellence. Thank you for keeping the atmosphere engaging, coordinated, and lively throughout the event. Please, can we also celebrate and appreciate the MC with a resounding round of applause? I would also like to appreciate the college alumni body for their consistent support and commitment towards the growth and development of the College of Sciences. Special appreciation to the President, Professor Adebayo, for leading and aiding the collective effort of the College of Health Sciences alumni body towards supporting impactful initiative and fostering continuous growth within the college community. Appreciation also goes to the planning committee, ably led by our dear Professor Amoni, Sir E.O. Zegbe, Thank you so much, Ma, for the sacrifices, coordination, and dedication invested into ensuring the success of this event. We truly do not take your effort for granted. Please let's put our hands together for her. Thank you so much, Ma. To all our faculty deans, lecturers, and members of staff, thank you for your continuous commitment to raising competent healthcare professionals and for continually investing in us academically and beyond. And to all students present here today, especially everyone who stayed to the very end, thank you for showing up, participating, and making every bit of the planning worthwhile. Your presence and engagement truly brought life to this program. The 18th Professor Grillo Distinguished Alumni Lecture hosts tomorrow, and we are honored to have Professor Mukaddas Akindele as our distinguished speaker. The lecture will take place at this same venue and will commence promptly by 10 a.m. and the colored bus will be available for transportation runs starting from 8 a.m. I wish us all safe journeys back to our respective destination, and I look forward to seeing everyone tomorrow. Thank you.
It can take time and effort. Mo ti gbìyànjú èmi stubborn. Ìwọ ló lè gbà mí ọgbọ́n.